Okay, thank you. Good morning, friends. I welcome you on behalf of Indian Medical Association Mumbai branch and IMA CGP sub-faculty Mumbai branch. Today, the webinar is on dysphagia. We have got all the experts who will share their knowledge regarding the dysphagia. The dysphagia word is very small, but the subject is very vast. So today we have got all the speakers from Sir H.N. Reliance Foundation Hospital and Research Center. Now the first speaker, I request our president to give a presidential address. Over to Dr. Jitesh Mehta. Dr. Jitesh Mehta. President, unmute. Dr. Jitesh Mehta.
Yeah.
So much, Usha.
PowerPoint.
And a very official and warm welcome to all of you on behalf of IMA Mumbai branch. This webinar is going to be very interesting. We have got stalwarts in their fields talking about it. So friends, even today, some doctors are getting sick and becoming positive, COVID positive. Vaccination, I don't know. I find that in my practice, I still come across patients who still refuse to take vaccination. I don't know what is the problem. They have got their own personal reasons why they don't take vaccination. We all try to, I keep on trying to, motivate them to take that vaccination. Until and unless all of us don't get vaccinated, I think that's going to linger on. So I don't know how you people are facing, and do you come across patients who are not ready to take vaccinations? It's still a task which is uphill. Friends, as you all know, since the last 2 months, we are having this membership promotion drive of IMA Mumbai branch. Not only Mumbai branch, IMA in general. All over India, there has been a decrease in the charges and there is a discount that is available till the end of this month. So just a brief recap of the activities that are happening. Just last month, last 4 days, 28, 29, 30, 31st of October, we had the IMA Olympiad, the Olympic, it was a national event which was held in IMA Nasik. More than 1,500 members participated in so many various events. And it was a great marathon event, a marathon get-together and a great mega event that happened and very successfully conducted. Everyone enjoyed. It was a great fellowship. All IMA people met over there. And IMA Mumbai branch is proud to say that we had our participants taking part, and our member, Dr. Disha Patel, she won 6 gold medals from our branch. She was representing our branch, and she won 6 gold medals in different categories like running, 100 meters running, javelin throw, shot put, and long jump, high jump, and so many whatnot. She's the daughter of our Dr. Arvind Patel. I don't know whether he's online. Our Joint Secretary, Dr. Arvind Patel. So, and we have got so many other activities, like we have got a singing competition just now going on online. So we have to send our entries, and the judges are eliminating the rounds. We are coming in from our part, from our Mumbai branch also, we have taken part. Then there is a Kathak competition also, where dance competition that is going on. And there also we are participating. Madam Kajal Ahuja also is there in that competition. So a lot of activities going on online also, and offline, where we meet sometimes, and this mega event was there. I think that is quite reason enough for all of you to become members of IMA. It's a very vibrant and a very important national body. Every doctor who is a medical doctor has to become a member of the IMA, allopathic doctor, modern medicine doctor. It should be compulsory in yourself. So with that few words, I will hand over the mic to Dr. Anil Awad to carry on the further proceedings. Thank you very much. Hello. Hello, Dr. Awad, you are not.
Yeah. Sorry.
I just forgot one more thing, and that is our conference that is coming up. That is 2nd of January 2022 at St. Regis. And I want all of you to take part in that. we are going to meet in person, hoping with our fingers crossed that everything goes well. And it shall be a very nice event. I'm sure everyone who is listening will be coming forward to attend our program. Thank you very much.
Yeah. Thank you very much, Dr. Jitesh. We'll just start with our CME. It's on dysphagia. We have got a panel of doctors, right from gastroenterologists, neurologists, and ENT specialists talking on the subject, dysphagia. But we will begin with the most senior person, I should say, Dr. Chetan Bhatt. He doesn't require any introduction. IMA knows Chetan Bhatt, and still, even at this stage of life, we enjoy listening to Dr. Chetan Bhatt. So I'll just shortly introduce Dr. Chetan Bhatt. Dr. Chetan Bhatt is the Director of Department of Gastroenterology and Hepatobiliary Sciences at Sir H.N. Reliance Foundation Hospital and Research Center. He has a vast teaching experience and is a very popular teacher and speaker for students as well as practitioners over 3 decades. He has won numerous scholarships, notably the Dr. A.G. Koyar Prize for Research Society, that is JJ Group of Hospitals and Grand Medical College, and the Glaxo Merit Scholarship. He has several publications and presentations to his credit in the area of gastroenterology and has authored chapters in API textbook of medicine. On diseases, on the diseases like peritoneum, liver, in systemic diseases and alcoholic liver diseases. He has special interest in motility disorders and inflammatory bowel diseases. He has special interest in motility disorders like inflammatory bowel diseases and has started patient education groups. He is chairperson of IBS Task Force of Indian Society of Gastroenterology. He is a core committee member of IBD Research Group and Task Force of Crohn's and Colitis Foundation of India. He has been organizing committee member of International Neurogastrointestinal Motility Disorder and Indian Society of Gastroenterology Conference in 2013 and 14. He has been the faculty member of International Inflammatory Bowel Disease Conference, National Conference of IBD, and National Conference in Gastroenterology over the past several years. With this introduction, I request Dr. Chetan Bhatt to begin his talk. Over to Dr. Chetan Bhatt.
Hello.
Yes, sir.
Can you see my slide?
No.
No.
Okay, one sec. Okay.
Go to the Zoom meeting and share slide.
Yes. One sec. Okay. Now 1 minute.
Yeah, we can see.
No, 1 minute. This is not my presentation. My presentation is different one, which I have updated today morning. Can I get that? Is it possible? 1 minute. I got it in a PowerPoint.
Go to this. It is on your desktop, no, Chetan?
Okay. Yes. Can you see now?
Yeah.
Yes, sir. Yes.
Okay. Fine. Now, at the onset, I would like to thank Dr. Jitesh Bhai, Ushaben, Anil, Bhai, everyone. You know, we have a very star-studded panel for today morning's discussion, and I'm very proud to have each one of them here with me. Dysphagia, even though it refers to like swallowing mechanism, but it is a multifactorial and a multi-system disease where you require a multi-system approach Not in every case, but in some cases, you require a multi-system approach. Now, what happens, like my today's talk, I'm giving an overview of dysphagia. Each speaker afterwards is going to define and discuss each of them in detail with you all. So it is unfair for me to cover everything in my first lecture and then the remaining speakers have nothing else to talk. So what I will do, I'll make my presentation very crisp and short so the other speaker can take over, and then in the end we'll discuss. I just wanted everybody to know that even though the food pipe starts at the level of cervical esophagus, but dysphagia mechanism involves the oral cavity, oropharynx. It involves the cricopharyngeal sphincter, cervical esophagus, thoracic esophagus, abdominal part of the esophagus, and also we have a cricopharyngeal sphincter and a lower esophageal sphincter. And all this is very important for the diagnosis, treatment, and management. Broadly, dysphagia can be classified as oropharyngeal dysphagia, which is mainly affecting the neuromuscular mechanism, where ENT doctor and neurologist comes into the picture, or many times even the oncosurgeon comes into the picture. It refers basically to the pharynx and upper esophageal sphincter. And if it is an inflammatory or infective pathology, you may get odynophagia. Dysphagia is difficult in swallowing. Odynophagia is a painful swallowing. So whenever you have odynophagia, it means a mucosal pathology also, that is a mucosal inflammation or mucosal infections. Then the other classification is esophageal dysphagia, which mainly involves the body of the esophagus, upper esophageal sphincter, lower esophageal sphincter, and gastric fundus. It is mainly mechanical, motor, or infective or inflammatory. So if you see the causes basically of dysphagia, oropharyngeal dysphagia is basically a neurogenic dysphagia, which may be because of the stroke. It may be a brainstem stroke. It can be lateral medullary syndrome, pica syndrome. It can be cerebrovascular accident. It can be neuromuscular junction pathology. It can be motor neuron disease. It can be bulbar palsy, pseudobulbar palsy. Any neurogenic cause like myasthenia gravis can produce oropharyngeal dysphagia. Structural pathology basically involves malignancies of the oral cavity, malignancies of the oropharyngeal area, Zenker's diverticulum, previous surgery, or any of the other pathology. Iatrogenic refers basically to any radiations or previous surgery, malignancy surgeries, or anything that refers to iatrogenic causes. Esophageal dysphagia, clinically, broadly, you can say it is infective or inflammatory. It can be motor or it can be mechanical. Motor is basically neuromuscular or a neuromotor mechanism, and mechanical is a mucosal or muscular or extraesophageal pathology. Clinically, most important thing in a dysphagia is a history taking. What most of the doctors, including clinicians like gastroenterologists, the resident doctors, many times do not pay much attention to the history taking. Today we have CT scan negative severe abdominal pain. Today we have CT scan negative headache. Slowly the art of history taking is getting obsolete, and only the higher investigations are taking place, which sometimes do not give you any accurate diagnosis, and you have to go back to the basics of medicine and take the history. So in the history taking of dysphagia, the onset of the dysphagia is very important, whether it's a sudden onset acute dysphagia or it's a slow onset dysphagia. Slow onset dysphagia can be progressive or non-progressive dysphagia. Now, most important thing, when you take the history, you ask patient whether dysphagia is only for the liquids or both liquids and solids or only for the solids. If it's only for the liquids, then probably oropharyngeal or cricopharyngeal sphincter mechanisms are involved, because the fluid takes a very less time to go from the mouth up to the cricopharyngeal sphincter. It takes about a second or less than a second for a fluid to reach. So by that time, if the cricopharyngeal sphincter has not opened up, you get a severe reflux, severe aspiration into the tracheobronchial tree. You can get cough, you can get choking, and person perceives there is a dysphagia. But there is no problem with the solid. The solid takes a little longer time. It gives time for the cricopharyngeal sphincter to open up. So the person can eat solid, but he has a problem with the liquids. So when you have this kind of history in a clinical presentation, think of the oropharyngeal or a neurogenic dysphagia. You can have both liquid and solid dysphagia. You ask patients, do you have problem with the liquid or solid? Patient says, doctor, kabhi liquid, kabhi solid. I have problem with both, I'm not sure what, but I have difficulty in swallowing liquid as well as the solids. If both are affected, then probably you're looking at the esophageal body mechanism, where it can be a motor dysphagia, it can be a nutcracker esophagus, it can be a diffuse esophageal spasm or a jackhammer esophagus. It can be any of these motor disorder of the esophagus. If it's only for the solid, then probably you're looking at a structural pathology of the esophagus. It can be a stricture, it can be web, it can be ring, or it can be malignancy. So liquid dysphagia is basically neurogenic, where Dr. Arun Bhai and Dr. Smita will take care of it. Liquid and solid both probably belongs to Dr. Sobhna Bhatia, and solid more than liquid and progressive dysphagia, Dr. Shankar Zanvar will take care of that. So we'll have specialists for each one of them, and we'll discuss in detail a little later. Now, how do you clinically, judge whether it's oropharyngeal dysphagia or esophageal dysphagia? Oropharyngeal dysphagia, if you ask person, he can localize very well. He says, sir, I cannot swallow, my food bolus remains in my mouth, I cannot take it down, or moment I start degluting, I start swallowing, I start coughing very badly, I start choking, I get sometimes I become breathless also. So there's probably a oropharyngeal dysphagia. Esophageal dysphagia, almost 60 to 70% of time patient can pinpoint. If the patient can put his finger on a sternum and say, doctor, I feel my food is getting stuck there, almost 70% of time you are accurately seeing the site of the pathology. In 30% of time, it may not be representative when there is a diffuse pathology, or if there is a pathology of the cricopharyngeal area or a G-junction. Many times the G-junction pathology inversely represents in a cervical area, or a cricopharyngeal pathology, or a pyriform fossa malignancy, sometimes refers only to the xiphisternal discomfort and pain. So barring such cases, almost 70% of time esophageal dysphagia can be localized. It presents mainly with a chest pain and regurgitation of the food, or at night time when the person lies down, the dribbling of saliva and soiling of the pillow. Oropharyngeal dysphagia, if it's a neurogenic, then basically person says, doctor, I cannot deglute, I cannot start my swallowing. This is called as a transfer dysphagia. He has a nasal voice, he has a dysarthria, diplopia, dysphonia, which refers to the neuromuscular abnormality like a myasthenia gravis. Drooling of saliva basically refers to the pharyngeal or bulbal paralysis. Muscle twitches or fasciculation refers to basically motor neuron disease. Progressive weakness, fatigability, drooping of eyelids again refers to the myasthenia gravis, and focal CNS deficit, there's a brainstem disease, or probably you have a bulbar palsy, or you have a pseudobulbar palsy, or you have a hemiplegia or a stroke. That you can easily differentiate oropharyngeal symptoms, neurogenic dysphagia. Esophageal pathology mainly of heartburn, chest pain, or squeezing feeling in the chest, or globus feeling. The globus hystericus is not the part of the dysphagia. Why it is not the part of the dysphagia? The globus hystericus, which was classically earlier described with iron deficiency anemia or a psychogenic anxiety-related symptoms, where the person in between the swallowing, person in between the eating food has like feeling of something getting stuck in the throat, but when he actually swallows, he can swallow it and there's no symptoms that time. So globus actually is not a part of the esophageal symptom. What you have in esophageal symptoms, other things, is a regurgitation of the undigested food, especially if you have achalasia cardia or a stricture of the esophagus with a dilated esophagus with the food getting stuck above the level of pathology. When the person lies down, the food or saliva dribbles out of the mouth. And if there is a persistent pathology or long-standing pathology or probably malignancy, you can look at the weight loss, which is significant weight loss. So most important is a type of the onset. Sudden onset, that is acute dysphagia, or a slow onset dysphagia that can be progressive or non-progressive. Sudden onset acute dysphagia is basically leads to history taking, and history taking is most important that time. You have esophagoscopy, probably you've done a sclerotherapy or variceal ligation, or you've done a dilatation of the esophagus, you've done a malignancy or stricture dilatation, and patient can develop the acute dysphagia for few days. Or person has got candidiasis or herpes simplex or eosinophilic esophagitis. So certain medications, which I'll be discussing little later, radiations, foreign body, corrosive injury, or even a neurogenic can present as an acute dysphagia. So if you see here, this is pill esophagitis. This is one of my patients. This was a young diamond trader, about 25, 30 years old, 25 years old, and he had severe dysphagia sudden onset, started just 2 days back. And he cannot swallow liquids, solid. He had a severe pain, odynophagia. Liquid he could swallow with a great difficulty, but solid he could not swallow. And history taking, I just asked him, have you taken any medication? He said, yes, sir, I had a probably cough, cold, fever, and my doctor had given me medicine. I said, did you take doxycycline? He was not aware of whether he taken doxycycline or not. So he showed me his prescription, there was a doxycycline. So now problem occurs with the pill esophagitis. There are numerous medications that can produce pill esophagitis. The number goes as high as 30, 40, 50 drugs can produce pill esophagitis. Majority of the antibiotics, doxycycline, clindamycin, clarithromycin, erythromycin, even quinolones can produce pill esophagitis. Various hypertensive drugs can produce pill esophagitis. All painkiller drugs, because they act on a prostaglandin mechanism, they can produce local problem and they can produce this. What is the main problem with doxycycline? There are two types of doxycycline available. One is a water soluble and second is an anhydrous one. So water soluble doxycycline is an alkaline pH of 7, whereas other doxycycline, the pH is 2. So now what is the difference between pH 2 and alkaline pH doxycycline? Alkaline pH doxycycline costs 7 to 10 rupees per tablet, whereas the pH 2 doxycycline costs 1 rupee per tablet. So it's a popular, people use, doxycycline with a lower pH, and the person takes with a less water, and the medicine gets stuck in the esophagus with a less water, and they produce this. Then various bisphosphonates, when you give a Sunday morning, early morning dose, 75 milligram, then you ask patient to stand up for half an hour. Various other drugs, hormonal pills also can produce, HIV drugs can also produce pill esophagitis. The history taking is very classical. The patient has taken a drug, within 48 to 72 hours, patient starts getting symptoms. Pill esophagitis, no need to worry, just give a treatment and patient becomes all right. Give PPI and prokinetic drug and antacids. Second problem is candidiasis, acute onset dysphagia. You can have a mild, moderate to very severe candidiasis. The first picture is mild candidiasis, and the last picture is very severe candidiasis. This can come with a acute dysphagia or recent onset dysphagia, and probably a diabetic patient, alcoholic patient, patient on steroid, patient on oral pumps. Patient taking steroid inhalers, you have to give a very standard advice that you gargle after each pump and you swallow 1 glass of water after you take the inhalers. When patient, a transplant patient, kidney transplant, liver transplant, patient on HIV drugs, patient with an immunocompromised state, all of them can get a esophageal candidiasis. Very unfortunately, recently, last 1 or 2 years, we are seeing too many candidiasis. Maybe COVID-19 has produced more candidiasis than steroid with the COVID has produced candidiasis, and even a doxycycline and antibiotics, even for longer period of time, that can also produce candidiasis. Another thing is sudden onset dysphagia. Just about 7 days back, 55-year-old gentleman came to me, known case of CA esophagus, already radiotherapy given and a chemotherapy given, and sudden onset dysphagia he came. We all were wondering whether it's a recurrence of malignancy. So we did a PET scan, was done early, first 2 days before, and PET scan showed marked improvement. So we couldn't understand that improvement of the disease, why persons who had acute severe dysphagia. When we did the scopy, the food bolus was stuck there. Patient had taken a coconut, the dried coconut, and a big piece of coconut was stuck there. This particular picture, this patient had a very severe reflux esophagitis, LA grade D, that is a Los Angeles classification, and a peanut was stuck here. We removed the peanut and dilated the stricture, patient improved remarkably. Then other infections of the esophagus like herpes simplex or a cytomegalovirus infection can produce severe dysphagia sudden onset. Then following a variceal banding, you do variceal banding for 3 to 7 days, patient can get a severe dysphagia. It depends upon the number of the band and how the band is applied. If the too much of the surrounding mucosa is taken, the dysphagia can persist for a longer time. Slow onset dysphagia, slow progressive dysphagia or non-progressive dysphagia. So progressive dysphagia is mechanical, that is malignancy or stricture. Non-progressive is a motor dysphagia or a web or a ring of the esophagus. Progressive mechanical dysphagia can start with initially only dysphagia for solid, then slowly progresses from solid to solid and semi-solid. After about few weeks to months, there's a liquid also he cannot take, so solid progresses to liquid dysphagia also, and later on he cannot even swallow his own saliva. So this is a progressive mechanical dysphagia. It mainly refers to a severe inflammatory pathology or a malignancy. But intermittent dysphagia, you can see a upper esophageal web like this, and this can lead to intermittent dysphagia, and which is non-progressive dysphagia. Or you see Sarski's ring on an endoscopy, Sarski's A ring or a B ring you see in an endoscopy, and a Sarski's ring can produce intermittent dysphagia, which is non-progressive. Another very important thing which we are diagnosing very regularly and we are seeing very commonly is a eosinophilic esophagitis. Any person who has a retrosternal burning or a reflux-like symptoms, and he complains to you that, doctor, intermittently I get difficulty in swallowing, my food is getting stuck in my food pipe, and I have to drink water to push it down. Probably you're looking at a eosinophilic esophagitis. And if you see the esophageal biopsy, eosinophil more than 20, probably you're looking at a eosinophilic esophagitis. Then you have a reflux esophagitis. Mild reflux esophagitis can have non-progressive intermittent dysphagia, but a very severe esophagitis, LA grade C or LA grade D, which leads to the stricture, can have progressive dysphagia. So these are all very severe circumferential esophagitis with a early stricture formation. And here you are seeing a stricture with multiple ulcers, and this can produce a stenosis of the esophagus and progressive dysphagia. Then you have corrosive injury scar. Corrosive injury scar can progress sometimes due to repeated fibrosis and can lead to progressive dysphagia and sometimes even difficulty to swallow even saliva also. Then you have achalasia cardia. You see a dilated esophagus with a large amount of food material or saliva or froth, or sometimes you can see vigorous achalasia or spastic achalasia, where you can see a good esophageal spasm, and you can still see a dilated esophagus, not very dilated, but significantly dilated, and it offers resistance to the passage of the scope. So these are all the various types of dysphagia. Then the progressive dysphagia can be a various types of polyps in the esophagus, or you can have a malignancy which progresses from the mild smaller lesion, which was starting as a mild initial dysphagia, which progresses to the severe dysphagia over a period of time. Another dysphagia is basically fundic-related dysphagia, gastric fundic-related dysphagia, and it is iatrogenic dysphagia, which is following anti-reflux surgery. Following anti-reflux surgery, when you take a gastric wrap around the esophagus, and it's too tight a wrap around the lower esophagus sphincter, then you can get a post-nasal fundoplication, you can get a dysphagia. So now, looking at all this dysphagia, what are the predisposing factors? Predisposing factors are basically heartburn and regurgitation, which tells you about the reflux disease. Then your NSAIDs, various NSAIDs, which can produce dysphagia due to the pill esophagitis. Antibiotics like doxycycline with a pH 2 doxycycline, powder doxycycline, can produce esophageal ulceration, pill esophagitis. Atopy, that is allergic rhinitis. 50% of eosinophilic esophagitis will have history of atopy in the past. So the allergic rhinitis, allergic asthma, you can diagnose eosinophilic esophagitis with a stricture. History of corrosive intake, you may have to very carefully take the history, past history in detail, or sometimes even radiations taken in the past for various reasons in a thoracic area. Esophageal surgery done in the past for the various reasons. And if you have a kind of a scleroderma, then you can have a predisposing factors for the, or risk factors for the dysphagia. Complications of the dysphagia. Complications of dysphagia can be recurrent sore throat, coughing, wheezing, recurrent chest infections, aspiration pneumonia, severe bronchopneumonia, severe lobar pneumonia, or even a bronchiectasis. Recurrent chest pain that can lead to unnecessary investigations like cardiac investigations, angiography. One of my patients, it was family physician practicing in our area, his uncle, and severe chest pain, atypical chest pain, angiography done, very critical block in a coronary, left anterior descending and circumflex, and multiple blocks. Patient was sent for the CABG. CABG was done. And after CABG, on a 10th day, patient said, I cannot swallow. Endoscopy done, CA esophagus. So the chest pain was because of the CA esophagus, and patient got diagnosed with a cardiac problem also with that. Change in the voice. Change in the voice may not sound as a complication to us, but a person who is singer, who's singing, his career depends upon his voice, may have a complication because of that. Weight loss because of the eating less, and sometimes person can get even dehydrated. So looking at all the general overview of the dysphagia, you learn from the experience. So at this stage, I will stop sharing my screen, and I will now leave it to the next speaker to take over my lecture. Dr. Anil Awad can take the next speaker.
Yeah. Thank you very much, Dr. Chetan Bhatt, sir. As sir said, we'll have there are no questions as such, but I'm sure we are going to have many questions as the CME progresses, and then we'll take the questions at right time. Now we go on to the next speaker, and
Okay.
Dr. Kajal.
Yeah.
Who is
Now, the next speaker is Dr. Arun Shah, and I request Dr. IMA CGP member Dr. Kashyap Dakshini to introduce the sir.
Yeah.
Good morning, friends. Dr. Arun Shah is a consultant neurologist and postgraduate teacher and director of the Department of Neurosciences at Sir H.N. Reliance Foundation Hospital and Research Center. Dr. Shah completed his MBBS from St. G.S. Medical College, Mumbai, and was awarded gold medal. Dr. Shah then completed his MD in internal medicine and DM neurology at the same institution. Dr. Shah completed a fellowship in cerebrovascular disease and stroke at the Oregon Health Sciences University, Portland, Oregon, USA. Dr. Shah was professor and head of the Department of Neurology at TN Medical College and Nair Hospital in Mumbai, and has trained and mentored several postgraduate students. Dr. Shah has been in clinical practice for 30 years with special interest in stroke, dementia, and neurocritical care. Dr. Shah was the first neurologist in Mumbai to use reperfusion therapy in acute stroke in 2002. And he presented his data on thrombolytic therapy of acute stroke in India at the World Congress of Neurology meeting held in Sydney, Australia in 2006. Dr. Shah is actively involved in clinical research in the field of stroke, dementia, and Parkinson's disease, and has delivered several lectures at various meetings. Dr. Shah directs acute stroke program at Stroke Ready Sir H.N. Reliance Foundation Hospital with stroke clinic for the young, and offers holistic care to patients at multiple sclerosis clinic, including latest disease-modifying therapy. Today, Dr. Shah will be talking on evaluation of neurologic dysphagia.
Sir, please unmute yourself. Sir, please unmute yourself. You're not audible. Dr. Anil?
Yes.
Dr. Shah is not audible.
No.
He's not
Sir,
unmuted.
sir, please unmute yourself, and you're not shared a screen.
Unmute. He's not unmuted.
You have to call him. Anil, call him.
No, sir has not. He has not shared the
Not
screen.
unmuted.
Sir, are you getting difficulty in sharing the screen?
Hello. Yeah, I'm having some difficulty in sharing, I think.
Yeah.
Now you're audible, yes.
Yeah, I just want to. Hello. I think when I share, it just shows me.
So your mail is open, na? That's why.
Oh, okay. So should I switch off the mail?
Yes. Yeah. No, you were doing it, but I don't know what happened. Yes.
Sorry for that.
Yes.
Yeah. Good morning to everyone, and thank you very much for the Dr. Chitesh and Dr. Awadh and to ask me to speak at this seminar. And also I thank Dr. Chetan Bhatt and Dr. Sobna Bhatia to include me as a faculty here. Now, I think Dr. Chetan Bhatt has covered very nicely, given a very nice introduction, and that has made our job easy. And I don't know, I will be just repeating some of the things which he has already said. The neurogenic dysphagia represents an enormous burden for patients, healthcare professionals like us, and also the speech therapists, the ENT person, and everybody, and the society in general. And somebody has estimated, I'm not sure how this estimation has come, that the prevalence of neurogenic dysphagia per year worldwide could be anywhere between 400,000 to 800,000. Maybe it may be more than this. As you see, it covers a gamut of neurological disorders, such as acute stroke, Parkinson's disease, dementing illnesses, which we discussed in the last one of the seminar, the motor neuron disease, Dr. Chetan had already referred to, neuromuscular disorders, inflammatory muscle disease, myasthenia gravis, and so on and so forth. So one of the important point to be remembered as a neurologist and of course a family physician, a dysphagia can lead to several complications with malnutrition, dehydration, and one of the most important problem which we face in neurology is aspiration pneumonia leads to life-threatening situation amounting to admission to intensive care unit. Hence, diagnosing neurogenic dysphagia as early as possible, probably, and appropriate management will save somebody's life. And also, now this is the small graphic representation, which I think Dr. Chetan has already shown, that neurogenic dysphagia is basically divided into oropharyngeal dysphagia versus esophageal, or oropharyngeal also known as transfer dysphagia. And we will be most probably limiting ourselves to this. Neurological is basically comes under the oropharyngeal. Muscular diseases also comes under oropharyngeal, and of course few structural causes of oropharyngeal, which we'll not be discussing. But as you see, neurogenic dysphagia also can be esophageal and is seen rarely. So what are the characteristics of transfer dysphagia or neurophagy? I think it's already been partly highlighted by Dr. Chetan Bhatt. They have initiation difficulty in initiating a swallow. They may point towards cervical region, the site of their symptoms, and swallowing may be accompanied by nasopharyngeal regurgitation. So if you have regurgitation history, that means fluid or some comes out from the nose while he swallows, then rest assured it is neurogenic. It can cause aspiration, and sometimes people will say that the food residue remains in the throat or in the pharynx. There will be associated drooling of saliva, food spillage, excessive salivation, piecemeal swallows, and of course, very often it will be associated with dysarthria or dysphagia. And some of them also may complain of, particularly people with bulbar weakness because of myasthenia or any other illnesses such as Parkinson's disease, may complain of coughing and choking while they eat. So symptoms of generally include dysphagia and swallowing include cough, dysphagia more for liquids than for solids, nasal regurgitation, and this strongly suggests a neurogenic process. It is important to remember that sometimes the people who have developed neurogenic dysphagia have associated impairment of sensorium or cognitive impairment, and that's why they may not complain of aspiration or complain of dysphagia, and that's why you should look for this in certain degenerative diseases. Particularly, you should look for this complication, even though patient may not come forward with the history of swallowing difficulty. So what are the history findings? I think Dr. Chetan has already emphasized all the points here: coughing or choking with swallowing, excessive tongue movements or spitting food out of mouth. They keep on moving their tongue to clear the throat all the time. They have poor control of tongue because the tongue muscles are weak sometimes. They have pocketing of food in mouth. When they talk, they have gurgly voice, particularly after eating. There may be hoarseness and breathy voice. They have prolonged time to eating, nasal regurgitation, difficulty in initiating swallowing, food sticking in the throat, and siluria. So see, that's the symptomatology of oropharyngeal dysphagia, and most often this will turn out to be neurogenic. So going back to the swallowing physiology a little bit. They have an oral preparatory stage, that is, food is grounded, chewed, and mixed with saliva to form a bolus, and that's the oral or preparatory stage. Then there is oral food is moved back through the mouth with a front to back squeezing action performed primarily by the tongue, and that's how we start eating. Then the bolus goes into the pharyngeal. You come to the pharyngeal phase of swallowing. Upper throat area, soft palate elevates, epiglottis closes of the trachea so that you don't aspirate, and the tongue moves backwards and the pharyngeal wall moves forward. These actions help force the food downward to the esophagus, beyond the larynx, beyond the epiglottis, and then you have the esophageal phase where your muscles propel food through the esophagus. The esophageal sphincter opens and closes efficiently. The bolus moves more to south. So these are the contemporary swallowing action which we have. So how does physiological swallowing? It comprises mixture of voluntary and reflex act. So voluntary act can be divided into oral phase, preparatory, and transport, and that's a voluntary. Then you have the pharyngeal phase, and you have the esophageal phase. Now, talking to neurophysiology of swallowing, we have a central control and you have control in the brainstem. So brainstem structures with cortical supervision and modulation emanating particularly from the inferior frontal precentral gyrus controls this. Supplementary motor area may play a role in preparation of volitional swallowing. So we think that we want to eat, then the supplementary motor area is activated. The anterior cingulate gyrus also involved in monitoring the autonomic and vegetative cellular function. So once it goes into the autonomic phase, that is when the bolus moves down below the pharynx, and then the anterior cingulate gyrus comes into the picture. And recently, people have shown that PET scan shows consistently there is activation of the left cerebellar region during swallowing. So this we have not still understood. That means cerebellum also indirectly plays part in the controlling the swallowing mechanism. So this is in itself the graphics representation of what we happens, that if you have peripheral stimuli of the oropharynx, larynx, your sensory neurons 5th, 7th, 9th, and 10th, and the cortical structures. Then you have the brainstem control centers, which are there in radicular formation, dorsal swallowing group, and ventral swallowing group. And then you have the nuclei of the 5th, 7th, ambiguous and hypoglossal nuclei, and of course uh, the hypoglossal and the neck muscles, pharyngeal muscles supplied by 7C2 also control the swallowing. Sorry, and the motor neurons, and then the oropharyngeal swells and primary stasis. So in general, this is how the neural control of swallowing goes. So the dorsomedial pattern generator, which I just shown, that is in the radical formation of the brainstem, involves the initiation and organization of swallowing sequence. The ventrolateral pattern generator lies near the nucleus ambiguous and directly controls motor output to the pharyngeal muscles and proximal muscles. A large network is required for this act of swallowing, which is obviously a complex act for us. So when you see a person with dysphagia from the neurological point of view, what are the things one should examine? General factors such as body habitus, drooling, and don't forget to examine mental status. How is his sensorium, as well as his intelligence and memory functions, judgment, and those executive functions also must be examined.
Hello. Sir, unmute yourself.
Unmute.
Sir, unmute yourself.
Call him.
Dr. Shah, sir, please unmute yourself.
Dr. Arun Shah, can you hear us? Call him, call him. Dr. Arun Shah, can you hear us? Ah, yes. Okay.
Sir, share your presentation again.
We can't hear you.
Hitesh, can you follow up, sir?
I'll do that.
Tell him to share his presentation again.
Yeah.
Sir, voice is not coming.
Hmm.
Wait, Jitesh is calling, sir.
Dr. Arun Shah, sir, please, we are not able to hear you. अनिल पीयूष को बोल दे, आवाज नहीं आ रहा है.
I'll call sir and see if he can. Just a minute. I'll call. Sir.
Okay,
Ritesh is calling, sir.
but he is not picking.
He was on the phone. He is speaking on the phone. Phone is in his hand.
Dr. Arun Shah, sir, can you hear us? We are not able to hear you, please.
Hello, sir.
The person you are speaking with. आप जिस व्यक्ति से बात कर रहे हैं, उसने आपकी कॉल को होल्ड पर रखा है. कृपया तुम्ही ज्या व्यक्तीशी बोलत आहात त्याने तुमच्या कृपया लाइन पर बने रहें. तुम्ही ज्या व्यक्तीशी बोलत आहात त्याने तुमच्या कॉलला होल्डवर ठेवला आहे. कृपया लाईनवरच राहा. The person you are speaking with has put your call on hold. Please stay on the line.
Ritesh.
आप जिस व्यक्ति से बात कर रहे हैं उसने आपकी कॉल को होल्ड पर रखा है.
Ritesh,
कृपया
phone बंद
लाइन
कर.
पर बने
Ritesh.
रहें. तुम्ही ज्या व्यक्ति
अनिल,
हाँ बोल.
हाँ, I don't know, कुछ प्रॉब्लम हो रहा है इनका.
Hello.
We'll go to the next speaker.
No. Let him.
Hello. Can you hear me now?
Yeah.
Yes, sir. Yes.
Okay, sorry that probably got problematic.
Sir, share your presentation again, sir.
Yeah.
Right, sir.
Sorry, the other computer was not giving me trouble. Sorry.
Correct, got it. No problem.
So I think we are at this. Yeah. So we are at the neurophysiology, so it has become evident that a large network of structures participate in the act of swallowing, especially volitional swallowing, which we just discussed. Examination we already covered. So what are the diagnostic tests available for assessment of people with neurogenic dysphagia? I think bedside what we do a time swallow test where 3 ounces of water swallow test is done. This is probably routine in every stroke patients when you go to ICU. Then if this is not sufficient, you do modified barium swallow, pharyngeal videoscopy, FACE and VFS. These are the 2 other tests which I think Dr. Smita is going to cover, but I'll just briefly touch with this. So FACE is a flexible endoscopy used to assess the pharyngeal and laryngeal anatomy and physiology. Usually we do assessment of secretions. The real food is used to see how it goes. There is minimal risk and contraindications. It is repeatable and can be done at bedside. So this is quite commonly used in ICU settings in people with dysphagia. And this is how you get an appearance of if something is sticking in vallecula, how is the larynx functioning. And then you have the video fluoroscopy, where this is done in radiology department. Almost like a barium-like material is given, and you see oral, pharyngeal, and esophageal stages, and gives us also real pictures whether there is any laryngeal spillage of the fluid, and whether there is any problem with the aspiration will be very clearly seen in this. The question is, it's generally not bedside possible. It's possible only in people who can go to radiology department. So sometimes in ICU care, we can't do this, but in or day-to-day OPD, of course, we can do this test. And this is how the picture you get. I wanted to just touch upon this because there are various endoscopic phenotyping of neurogenic dysphagia, which is generally mentioned here, just to be seen. So for example, you have premature spillage. Generally will occur in people who are motor neuron disease, and certain central disorders also can give you same like PSP or frontotemporal dementia. So probably the endoscopic phenotyping helps us a little bit to assess and correlate with the neurological problem of the person. So I'll not go into more details because I think Dr. Smita will probably cover this aspect a little better. So it's important to remember that sometimes in OPD patients, dysphagia etiology and becomes difficult. Particularly, I remember a patient recently who presented with change in voice and probably food sticking in the throat, had dysphagia for liquids and also for solids, and solids he had to take water and put it down. So it appeared to us as a mechanical dysphagia, but then she had associated pulling of saliva, she had 9/10 involvement, and we thought that it was neurogenic dysphagia. So sometimes it can be very difficult to find out etiology, and that's why we require a series of diagnostic workup with the flow chart which is mentioned here. The obviously initial diagnostic workup consists of detailed history taking, neurological examination, which I already pointed out, and one could do a phase following standard protocol to see what's going on. So if this is not, you do not arrive at a diagnosis or you arrive at a working diagnosis, then you require advanced diagnostic workup like MRI brain to see the brainstem structures properly. You may require CSF at times if you suspect Guillain-Barré syndrome variant, which is causing the dysphagia, and you could require a tensilon test along with FACE, basically to confirm your diagnosis of myasthenia gravis. And if even this workup is not sufficient, then you go on further advanced workup, which would consist of VFSS, that is video fluoroscopic swallowing study, the manometric study, which I think Dr. Sobna Bhatia is going to correct, neurophysiological examination like EMG and repetitive muscle tests, whole body MRI, MRI of the cervical spine, detailed antibody testing to see if you're missing some abnormal myositis or mitochondrial disorders or neuromuscular disorders, and rarely muscle biopsy. So evaluation of dysphagia goes in a stepwise fashion, and if the initial diagnostic workup suffices, then you don't have to go to the rest of the workup which I have just mentioned. But this lecture was basically for evaluation, and that's why I'm focusing on this slide a little more. So coming to the causes of dysphagia in neurologic practice, I have divided into two categories: neurogenic dysphagia in ICU and neurogenic dysphagia in OPD. Now, ICU, as you see, various diseases which I mentioned here, like hemispheric infarct or hemispheric intracerebral hemorrhage, or something else, which is involving a sensitive area of the brain, such as Broca's area or the insular cortex, medial medullary stroke seen in this graph, or lateral medullary stroke. These are common causes of neurogenic dysphagia in ICU setting, and this is called post-stroke dysphagia. Now, this is a topic I must emphasize. I have probably talked about this in different setting also, is important because the post-stroke dysphagia is a very common morbidity, mortality factor in acute stroke outcome. So incidence of aspiration in acute phase of stroke varies from 16% to 52%. So it can go as many as 50% of patients admitted with acute stroke may have neurogenic dysphagia. And silent aspirations occur from anywhere from 8% to 27%. And you can identify aspirators, which could be it could go to almost 2/3 of patients may have developed silent aspiration when you identify the aspirators. And so when you see a person of acute stroke, which are the factors which should lead for you to think that he could have a dysphagia and aspiration, which are particularly people who have delayed swallow when you give them water. They have reduced paresthesia and pharyngeal muscles. There is movements of pharynx are affected. Gag reflex is down. and abnormal volitional coughing and cough with swallow. When you cough, whenever they swallow, they cough. Dysphonia, soft palatal dysfunction, and facial hyperesthesia. So if you have all these, then chances are that person with acute stroke has neurogenic dysphagia, and he should be managed accordingly. So post-stroke dysphagia and aspiration correlation with lesion size. So this just to complete, we already had discussed the neurophysiology of swallowing. So anywhere lesions there probably will give you. Just to dilate that people who have lower brainstem lesion, medullary lesion will have swallow impairment because of major swallowing centers are affected. The higher brainstem lesions like pontine lesions, bilateral, can also give you swallowing reflex, which because of the hypertonicity and delay in triggering the swallow reflex. Subcortical lesions may affect motor as well as sensory pathways. Left hemispheric people, even though they may not have bulbar weakness, they may have apraxia. That means the muscles are not weak, but the idea of swallowing is not proper, and they get apraxic associated dysphagia. And right hemispheric region may have neglect associated dysphagia with main problems of the pharyngeal phase of swallowing because they neglect the house. So they have dense hemiparesis. They probably keep the mouth open, and if you feed them from the left side, they would probably not realize that they are feeding. So you have to feed them from the right side and probably try to overcome the neglect. So there are guidelines for dysphagia by American Heart Association, which we also follow. Dysphagia screening before the patient begins eating. So every patient who comes in EMS or ICU with acute stroke is screened for dysphagia by a nurse initially, and then the physician if required. Then if is established dysphagia, then at sometimes we do endoscopic evaluation as well, that is face as well as video fluoroscopy as and when required. And then the alternative way of feeding is established, and they are probably taken care of by proper nursing management to avoid aspiration pneumonia. So when you come to dysphagia in neurology OPD, there are various the diseases which can be classified into three groups. People who have degenerative brain diseases, which we'll go into detail a little bit: Parkinson's disease, progressive supranuclear palsy, multisystem atrophy. These are the extrapyramidal disorders which may be associated with dysphagia. Then degenerative dementia such as Alzheimer's dementia, frontotemporal dementia, or Lewy body dementia also can be associated with dysphagia when they are in advanced stage. Dystonia, particularly drug-induced dystonias, can be associated with orofacial dyskinesia and dystonia. And then, of course, the commonest cause of dysphagia in neurology OPD, which one should never miss, is myasthenia gravis, the motor neuron disease, inflammatory myositis, particularly dermatomyositis, and Guillain-Barré variant. And miscellaneous causes of bulbar palsy, such as diphtheria, can present with bulbar palsy and can cause neurogenic dysphagia. So I'll just highlight, if the time permits, I'll just finish a few more minutes. Is the time okay with me? Yeah. So in Parkinson's disease, the symptoms of dysphagia are difficulty in bolus manipulation and control, dryness of mouth, delay in initiation of pharyngeal swallow, residue in pharynx, abnormal airway somatosensory function, decreased upper esophageal opening and relaxation, and they also have silent aspiration. But this, mind you, early phase of Parkinson's disease, dysphagia is not common, and dysphagia does not occur in every patient of Parkinson's disease. It affects probably 20 to 30% of people with advanced Parkinson's disease. But during the course of their disease, 90% will develop dysphagia. Motility disorders in all phases. And the only point I wanted to make about is the dysphagia in Parkinson's disease, and of course the bradyphrenia and voice can be properly treated with what is known as Lee-Silverman voice treatment program. So it's a probably rehabilitation program which involves think loud and think shout. You know, this is how they train, and this is the technique which I think speech therapists use very often. And it's scientifically proved, and the people have done a PET scan and shown that after the therapy, the PET scan shows that images appear more similar to healthy individuals. So it's a helpful treatment, scientifically proven. So probably if you have people with Parkinson's disease who have dysphagia and speech problem, they should undergo this speech therapy, and that might help them. And in PSP, also dysphagia is very common, particularly dysarthria and dysphagia, and early alternative nutritional therapy such as PEG should be done in people with PSP. In MSA, you have few people who may develop dysphagia, but they have more often problem with laryngeal stridor rather than dysphagia. In Alzheimer's disease, in advanced cases, again, alternative way of following is required because they have agnosia, they have understanding is goes, and in people, it's very difficult to feed advanced Alzheimer's patients because of their cooperation is also poor. They forget to chew, they keep the bolus inside, and probably they may aspirate. So this dysphagia is a real problem in advanced Alzheimer's disease. The other types of dementia also may be associated with similar. The mechanisms may be somewhat different, but they all have probably understanding and cognition as a major underlying reason for the dysphagia. I wanted to emphasize this, that you may have people who are have heartburn and acid-peptic problem, and are they given a combination, rabeprazole L or pentodec L, and they come back to us after 6-8 months with difficulty in speaking and difficulty in swallowing, and they may have tardive dystonia or tardive dyskinesia as shown in various features, and which could be cause of dysphagia. So people who are on antipsychotic therapy for long term, or people who are on levodopa may develop dysphagia and orofacial dyskinesia, which should be remembered, and we should probably monitor your drug therapy with patients. They develop this complication. Of course, omission of drugs, some people reverse, not everybody reverses. Neuromuscular disorders, only point I wanted to make about bulbar myasthenia, onset with bulbar symptoms are common, particularly in elderly and those with anti-musk antibodies. You know, there are myasthenia, some of them, about 15% have anti-musk antibodies, and they very often present with bulbar symptoms. The point to remember is they have more difficulty in swallowing liquids, and particularly hot food worsens dysarthria and dysphagia in patients with myasthenia gravis. So if you take a history and they tell you, particularly they have more problem if they are eating hot soup, they are drinking, or hot cup of coffee, they are having more difficulty, think of myasthenia. Then sometimes recently we have post-COVID Guillain-Barré syndromes, which we presented with dysphagia and dysphonia. So the Miller-Fisher variant of Guillain-Barré syndrome may not present with limb weakness, but it may present with difficulty in swallowing. Dermatomyositis can also present the same, and motor neuron disease. So all these neuromuscular disorders can present with dysphagia in neurology OPD. The management issues, of course, rehabilitation is the main thing in this. Alternative feeding methods to prevent aspiration pneumonia should be instituted as early as possible to prevent ICU admissions. People who develop cricopharyngeal spasm may benefit from Botox therapy. This is particularly common in people with Parkinson's disease. And if you have myasthenia, pyridostigmine should help, and electrical stimulation in acute stroke. Dysphagia is being practiced, but still not approved and not proven with evidence-based medicine. Thank you.
Thank you, Dr. Arun.
Yeah, thank you very
Arun
much.
Shah.
Sorry for the technical problem.
Yeah, it's okay. Anil, question answer will be shared later on, no?
Sir, you'll be there till the end?
No, Dr. Anil, I might have to go to Bridge Candy for a round. So.
Okay. I'll just ask you one question.
Yes, please.
Will speech therapy help in the cases of dysphagia? This is one of the questions asked by one delegate.
Yes, definitely. No, I think these swallow therapy, speech therapy, electrical stimulation are being all planned, and I think there are certain centers which already do electrical stimulation of the pharyngeal muscles and all that. So I think rehab is the most important part, and it does help. I think it does help. And some evidence following post-stroke of electrical stimulation is still not that much to support it. But in diseases such as Parkinson's disease and all that is all evidence-based that speech therapy and swallow therapy helps.
Okay. And sir, how much when we talk about progressive dysphagia, how much time it takes from the first stage till the last stage?
Kajal, Dr. Kajal, please unmute.
Hello. Yeah, say again.
Yeah. How much, in case of a progressive dysphagia, how much time usually takes from the first stage to the last stage?
Amongst the degenerative diseases, the dysphagia probably certain diseases, the dysphagia comes up very early, and that is probably the progressive supranuclear palsy.
Yeah.
While if you take patients of Parkinson's disease, I think we know now that Parkinson's disease has different progress with different, some are slow progressors, some are fast progressors. And in most often in my practice and observations, the dysphagia would come up almost after 10-12 years of Parkinson's management. Very few patients will have early dysphagia. While in progressive supranuclear palsy, dysphagia would see in first 3 years itself, The Alzheimer's and all that, probably again, it comes only in advanced stages. It doesn't come up very early.
Right. Thank you very much, sir.
Yeah.
We would have been very happy if we would have joined the panel discussion at the end. But nevertheless, thank you very much.
Thank you. Thank you very much.
Yeah.
Thank you, Dr.
Yeah. Dr. Usha. Yeah.
Yeah. Thank you, Dr. Arun Shah, for giving an excellent representation. Now we'll move to the next speaker, Dr. Shankar Zanvar. I request Assistant Secretary, IMA CGP Subfaculty, Dr. Kajal Ahuja, to introduce Dr. Shankar Zanvar.
Dr. Shankar Zanvar is a consultant gastroenterologist and hepatologist at Care Hospitals, Nagpur, and visiting consultant at various other prominent hospitals in Nagpur. He has worked as assistant professor in gastroenterology and hepatology at Christian Medical College, Vellore. He did his MBBS from Jawaharlal Nehru Medical College, Wardha, followed by MD Medicine from Shri M.P. Shah Government Medical College, Jamnagar, Gujarat. He then completed DNB Gastroenterology from Apollo Hospitals, Chennai, Tamil Nadu. He also did postgraduate program in neurogastroenterology from Ajoy University, Suwon, South Korea. He introduced and successfully performed plasma exchange therapy for acute liver failure patients in Nagpur. He also performed first EUS guided liver abscess drainage in Central India region. He has experience in performing all kinds of endoscopic procedures, including foreign body removal, capsule endoscopy, PEG insertion, narrowband imaging scopy, ERCP, endosonography, EUS, high resolution manometry, pH studies, biofeedback therapies, and fibroscan. His special interests are pancreatology, neurogastroenterology, and endoscopic ultrasound. He has attended numerous national and international conferences and is a keen researcher. Today, he'll be speaking on evaluation of esophageal dysphagia, symptom analysis, and mechanical dysphagia. Over to Dr. Shankar Zanvar.
Madam, I am unable to share my screen. Once the screen share is stopped, I can share my screen.
Yeah.
Dr. Anil?
Yes.
Yeah, he is not able to share his screen. Just help him.
No. This prior screen share has to go, madam. Yeah, thank you.
Okay.
So at the outset, I would like, am I audible now? My screen visible?
Yes.
So at the outset, I would like to thank IMA and Director of our department, Dr. Bhatt, for letting me present on this platform. I would like to make a small correction that the CV which was shared was the older one. I have moved to Mumbai and now I have joined Dr. Bhatt's department as consultant gastroenterology and a full-timer at HN Reliance Hospital. So I'll be talking today about mechanical dysphagia. So mechanical dysphagia predominantly can be classified based on the causes. The commonest cause is benign, which includes rings, webs, strictures, duplication cysts, Zanker's diverticulum, and foreign bodies. There could be malignancies, adenocarcinomas, squamous cell carcinomas, or other neoplasias in the wall. And there could be extraneous impressions. So in benign mechanical dysphagia, we first talk about esophageal webs. These are developmental anomaly. One or more thin horizontal stratified squamous cell membrane are seen in the upper esophagus. This is the barium picture of this web. It is typically seen in the upper or mid esophagus. It rarely encircles. It is commonly in the anterior wall. Nearly 5% are asymptomatic. It is the commonest presentation here is dysphagia for solid, and it usually responds to bougie dilators. I shall come to the bougie dilators later. It is also associated with iron deficiency anemia. It was especially identified in patients with celiac-related iron deficiency anemia by Plummer-Vinson, and thus the name Plummer-Vinson-Peterson-Kelly syndrome. It has a significantly high risk for squamous cell carcinoma. So the standard teaching is whenever one finds a web, it has to be biopsied, especially in patients who are older than 50 years of age. Next comes esophageal rings. These are seen in the lower esophagus. There are two types of rings predominantly. The first ring is called as type A ring, and the second ring is called as type B ring. Type A ring is uncommon and it is a muscular ring. It happens due to hypertrophied muscles. It is generally asymptomatic, and when symptomatic, it responds to bougies or botulinum toxins. Type B ring is known to most of us. It is Schatzki's ring. It is usually seen at the squamocolumnar junction. It is non-muscular. It is just thickening of the mucosa. It is seen in almost 1/10 of the endoscopies we do every day. Usually, it is associated with hiatus hernia. It responds commonly with PPI therapy, does not need any specific endoscopic therapy. If it is significant enough and causing significant dysphagia, it can be treated with endoscopic incisions or bougie dilatations. Then comes the commonest and the most difficult benign esophageal dysphagia cause, that is esophageal strictures. So the common causes of esophageal strictures are peptic stricture, which can happen due to reflux esophagitis or in patients with scleroderma when there is no peristalsis and the acid keeps coming back into the esophagus from the stomach. It can be also related to corrosive ingestion. It could be after surgeries in the anastomotic stricture type. It could be after radiation therapy for CA esophagus or laryngotracheal malignancies also. It can happen after pill ingestion, as Dr. Bhatt has already explained in his initiation talk, where pill esophagitis can happen. If it goes for long and if it is undetected, it can lead to strictures. It can also happen after infections. Eosinophilic esophagitis, I'll come to details of eosinophilic esophagitis a little later. It can be associated with skin disease, that is bullous pemphigoid. So how do we diagnose the strictures? The easiest way to diagnose stricture is, after the history obviously, is barium study, that is barium swallow. One can see a narrowing in the mid esophagus here. The upper column of barium is significantly significantly dilated. The mid part of the barium is constricted and the distal parts appears little normal. Then another technique for diagnosis is endoscopy. In endoscopy, we find difficulty in traversing the routine endoscope through the stricture. So how do we treat this? So I had mentioned this bougie term 2 or 3 times earlier. Bougie is nothing but a candle-like long fibrous tube which dilates the esophagus when lubricated. We do serially increasing size of bougies. We introduce these bougies over the guide wire into the esophagus and dilate the esophagus. When the stricture is small and short and regular, we use balloons. This is one of our case which we did few weeks back. There was narrowing in the mid esophagus. We introduced the guide wire, then we introduced the balloon, and when the balloon was deflated, now we can see a significantly dilated esophagus, which would allow normal food to go inside. So the normal diameter of the esophagus, which is required for swallowing of food particles that is solid, is at least 12.5 to 14 millimeter. So this is picture of pre and post dilatation of the same patient. One can see the balloon here. Once the balloon is dilated, now the stricture is gone. If the strictures are persisting and not responding to bougie or balloon, we might use stents. I shall come to the stents little later. And if nothing works, surgery is the only last option. The other benign causes include duplication cyst. Duplication cyst is nothing but a 3-layered inclusion within the esophageal, duodenal, gastric, or for that matter, in the whole of the GI tract, a 3-layered luminal inclusion within the wall of the GI tract. So one can see a outpouching here with extraneous impression. Once this is seen, we now know that the lesion is subepithelial. If the department is equipped, as is ours, with endoscopic ultrasound, we can on the same time find out the content of this mass. And once we do the endoscopic ultrasound, we see an anechoic area. That means the cyst is anechoic and it contains liquid. I meant the subepithelial lesion is cystic because the content was anechoic. Then we come to Zanker's diverticulum. Zanker's diverticulum happens due to thickened cricopharyngeal bar at the upper esophagus, which leads to the outpouching at the posterior pharyngeal wall. It typically is seen in patients who are septa or octogenarian, who have complaints of dysphagia along with foul-smelling regurgitation after they swallow the food. Then we come to foreign bodies. This is our own case. This was a young boy who presented with dysphagia, who had swallowed the seed of a fruit and was unable to swallow it further.
You're not audible.
In a small size esophagus, when the food is swallowed, nothing but endoscopy will help to remove this foreign. Malignant causes of dysphagia. Am I audible now?
Yes, sir. Yes, sir.
Thank you. Sorry for that technical glitch. So probably the internet speed is variations here. So the predisposing factors, as I was mentioning, were alcohol, smoking, nutritional deficiencies, and high starch diet for squamous cell carcinoma. Then comes in the list is adenocarcinoma. 50 to 60 years age bracket is the common age of presentation. More common in females, more common in males than females. It is 8 times more commoner in females compared to, in males compared to females. It is seen more commonly in the lower esophagus. Happens when somebody is obese or smokes a lot or has reflux esophagitis, which leads to Barrett's esophagus, which is known to all of us is a pre-malignant condition. So I wouldn't quote international data. I'm quoting our own Mumbai data. And this is a study from SAN, which was done last year. It was a prospective study, retrospective study. They included total of 552 cases of squamous cell carcinoma from 1996 to 2015. The mean age of presentation in patients of Mumbai coming to Mumbai was 54.8 years for malignant dysphagia. It was commoner in female. Most common type was squamous cell carcinoma. Almost 80% had squamous cell carcinoma. The most common location was mid esophagus, followed by lower esophagus. And now we are seeing increasing rates of lower esophageal cancer, that is adenocarcinoma. And it is increasing because of the increasing obesity and poor lifestyle changes, which predispose one to reflux esophagitis, Barrett's, and as I said, Barrett's is a pre-malignant condition. So now we come to a very interesting entity of eosinophilic esophagitis. One can note there are many pinkish cells within this blue and slightly less pinkish areas of these cells. This is biopsy from mid-esophagus. One can note these pinkish cells, which are nothing but eosinophils. So it presents as dysphagia, reflux, chest pain, food bolus infection. Food bolus infection, particularly in a patient who had no history of stricture, should raise an alarm of eosinophilic esophagitis. They also have non-cardiac chest pain. So how do we diagnose esophagitis? It would correlate with peripheral eosinophilia. It doesn't correlate always that well. So endoscopic appearance, I'll show in the next slide, is an indicator or raises suspicion of eosinophilic esophagitis. On histology, we find more than 15 cells per high power field in the mid-esophagus, and these persist even after proton pump inhibitor therapy. So how do we treat it? The most easiest way to treat is 6 food elimination, since it is a sort of allergic, it is a sort of intolerance related esophagitis. We have to eliminate cow's milk, soy, wheat, egg, peanuts, or seafood. If that doesn't help the patient, we have to introduce steroids. These steroids are not oral, they have to be inhaled without spacer. And newer drugs in line are mepolizumab and reslizumab, which are not available in India, yet to get available. So these are pictures of eosinophilic esophagitis. We see corrugations in the esophagus, trachealization of esophagus. There could be crepey paper appearance of esophagus. All this indicate that these patients might be having eosinophilic esophagitis. A point to be noted is just lower esophageal endoscopy guided biopsies are not enough, and we have to also take biopsies from mid-esophagus. So this might not come as a good thing for a patient who has already undergone endoscopy for dysphagia. Many a times we have to repeat and explain them, since the lower esophageal biopsy was not taken, we have to do again. It's a tough time for us to explain to a patient who has recently undergone endoscopies. Then we come to malignant dysphagia. This part had been management of malignant dysphagia, presentation of malignant dysphagia. So malignant dysphagia presents as progressive dysphagia. It is more for solids than for liquids. There is weight loss, pain, hoarseness of voice, cough. How do we work up? So endoscopy is the first and foremost test, though academicians would say barium is the first test, but to be true in today's day, barium is not considered to be the first test when the clinical suspicion is malignant dysphagia. So we do endoscopy and biopsy. The endoscopic picture itself is sufficient to tell us that the person could be harboring a neoplastic lesion. To know the extent and metastasis, we do CT scan of chest and abdomen. So how do we manage? When the lesion is operable, the first and foremost treatment is surgery. If the lesion is not operable, especially in the upper part of the esophagus, chemoradiotherapy is the treatment of choice. Endoscopy has a role in management of malignant dysphagia. It could be curative, that is endoscopic mucosal resection or endoscopic submucosal dissection can be done. Or it could be palliative. This EMR and ESD, that is endoscopic mucosal resection and endoscopic submucosal dissection, are especially reserved for patients who have esophageal malignancies which are in its early stages. Then we come to palliative treatment, that is esophageal stenting. So I take pride being the part of a department which is equipped with one of the best endoscopes in the country. This is the case which we did only yesterday. This lesion appears to be non-malignant on endoscopy, on the white light endoscopy, but now we are equipped with a very high definition narrow band imaging, which shows that the smaller vasculature which cannot be identified on normal white light can be identified on narrow band imaging and magnification, and this probably is dysplastic. We are yet to receive the biopsy pictures. Once that is there, we are quite confident that this would turn out to be a malignant lesion or at least a severely dysplastic lesion. So once we find these lesions, we have now, as I have said earlier, endoscopic mucosal resection or endoscopic submucosal dissection. We mark the area, we go around the area, incising it, and the tissue can be taken out just as a surgical sample in totality. And most of the times, the R0 resection can be achieved with very frequent negative margins. Then we come to palliative treatment as esophageal stenting. This picture, I would like to share that this patient had tracheoesophageal fistula along with carcinoma esophagus. Stent was introduced. Not only the tracheoesophageal fistula healed, but also the dysphagia resolved. I do have the video. So my video is visible now?
Yes,
so
sir.
This is the case, and this is the video. After the stenting, the dysphagia is gone. And we can see once the stent is placed, the malignancy is pushed to the side, and the patient has a way for ingestion of the food. Then we come to rare tumors, that is, those can be benign or malignant. It could be leiomyomas. This is the lesion we saw on endoscopy. This was again subepithelial. Once we are equipped with a center where both endoscopy and endoscopic ultrasound is available, at the same moment, we can put an endoscopic ultrasound and we can find out the layer of origin. And here we can see it is arising from a hypoechoic layer, which is a muscular layer. And this area is the tumor. Then there could be gastrointestinal stromal tumors. Now we are equipped not only to visualize and localize these lesions and take biopsies from them, because the endoscopic biopsies would not be helpful. So we go endoscopic ultrasound guided way. Once the biopsy is in hand and we know that this lesion is localized only to the muscular layer and not running deep, we incise the we incise the esophageal mucosa, we go into the submucosa, we make a tunnel, and we remove the tumor. This is called endoscopic tunneling and mucosal resection. So this is the picture, that this is the lesion, a tunnel is made, we can see the tumor in toto, the tumor is removed, this is the raw area, and this is the removed tumor. All this is done directly and only endoscopically. The patient does not have to go under a formal full-fledged surgery. And the patient can be discharged on at the most 2 or 3 days after the procedure. Then we have extraneous causes, that is cervical osteophytes, dysphagia lusoria, which is because of aberrant subclavian artery, enlarged mediastinal masses, of which mediastinal lymph nodes, which could be tubercular, lymphomatous, or metastatic lymph nodes. There could be an aortic aneurysm, which is causing dysphagia. It can also happen due to carcinoma of lung, mediastinal sarcomas. So these are some pictorial representation. This is an 84-year-old lady who had dysphagia. We could not pass the scope further. We did an barium esophagogram, and then we identified cervical osteophyte. This is one particular condition where endoscopy is contraindicated. Putting the endoscope would harm the patient more than benefit. So I would just tell our recent experience in this field of beyond the routine endoscopy, that this was a lesion seen by another gastroenterologist. Multiple biopsies were taken. This had happened twice. There was no lesion identified. Then a CT scan was done. A lesion was seen just near the esophagus, but the exact nature of the lesion could not be identified. We did endoscopic ultrasound. There was a lymph node seen. There was a mass seen. We did endoscopic ultrasound guided biopsy, and what we found was a lymphomatous node, and that was causing dysphagia. And this would not have been picked up on a routine endoscopy. So I would like to share our recent experience on in last 3 years. We have done more than 30 lesions of mediastinal lymphadenopathy, which would not be identified on endoscopy, or CT guided sampling would be difficult. So in this group of lesions, we found TB as the most common cause. The next in line was lymphoma. We had few cases of anthracosis related lymphadenopathies. 9% cases were inconclusive, and CA lung was seen in 9% of cases. So what I would like to iterate here is endoscopic ultrasound guided biopsies for mediastinal lesion, especially subcarinal or aortopulmonary lymph node, is much less invasive than CT guided or endoscopic endobronchial ultrasound guided, and this can give exclusively better results than the other modalities. Thanks a lot for patient listening. I hope this was not very difficult to swallow.
Thank you, sir. Sir, I want to ask one question. In
Yes,
squamous cell carcinoma of the base of the tongue can also lead to dysphagia, no? Because
Yes,
of
ma'am.
the
It can definitely lead to dysphagia when it has reached to the laryngopharyngeal region also, or it can also lead to transfer dysphagia.
okay. Are you going to stay till end, sir, in the question answer session?
Yes, ma'am. I would stay, ma'am.
Okay, okay. Thank you, sir. Then we'll ask the question later on.
Dr. Usha,
No issues, ma'am.
Dr.
Yeah.
Usha Shah,
Yeah.
before we go on to the next lecture, which I am going to introduce, Dr. Karthik Ganeshan, I have a small presentation. This is regarding the vasectomy center, which
Yes.
our branch is starting.
Yeah, sure.
Friends, this is to tell you that you must be aware that IMA Mumbai branch is starting a newly renovated vasectomy center. We are in maybe within a 15 days time, we are going to start it. And here the vasectomy will be performed by highly trained surgeons, and people who get vasectomy done, and the people who are doctors who are going to motivating the people will get a handsome remuneration for the same. This is just a brief review of our center. This is the entrance, and of course, this is the lobby. This is the OT, which is well equipped, and we can see the new LED lights, which are the current concept in OT. These are the recovering rooms, and this is a doctor's cabin. And there is one more announcement that we have got a vacancy for one part-time medical officer, and any doctor who is interested can contact the IMA office. The numbers are 75067 35383 and 89283 Just take down this number, and any doctor who is interested, these are part-time jobs, so they can just call up the number and they can find out the details from the office. Thank you very much. And now we move on to the
next speaker.
Speaker.
The next speaker is Dr. Karthik Ganesh. I request President-elect Dr. Anil Avar to introduce the speaker.
Yeah, thank you, Dr. Shasha. Dr. Karthik Ganeshan is a consultant radiologist, head of CT and MRI, and the division chief for body imaging at Sir H.N. Reliance Foundation Hospital and Research Center. He is also director of AP Workshop and Training. After completing his MBBS and DNB, he successfully accomplished fellowship in MRI and fellowship in advanced liver imaging from the University of California, San Diego. Throughout his illustrious academic career, he received several scholarships, including the Amar Gandhi Scholarship for Best Clinical Associate in Jaslok Hospital and Jain Tata Endowment Scholarship. He also has received the Har Gobind Foundation Medical Fellowship and Fellowship of the Society of Abdominal Radiology. He has several peer-reviewed index publications to his credit and peer-reviewed scientific abstracts and educational exhibits and posters. He was also awarded the Best Poster Award by the Society of Abdominal Imaging in 2013. He is the co-author of the Hepatic Iron Overload in Abdominal Imaging. He has also authored 2 chapters in cross-sectional imaging of abdomen and pelvis by Springer Publications. He is visiting professor at the University of British Columbia, Vancouver, Canada. His special interests are body imaging, head and neck imaging, and neuroimaging with functional MRI. I request Dr. Ganeshan to begin his talk on radiologist perspective. Over to Dr. Karthik Ganeshan.
Good morning, everybody. Thank you, Dr. Anil and Dr. Jitesh, for this invitation to speak today. Also, I would like to thank Dr. Chetan Bhatt and Dr. Shobna Bhatia for adding me on as co-panelists for this session on dysphagia and the role of how imaging and all a multimodal approach to dysphagia itself. So without further ado, I'll just take this, I'll just share my screen and just let me know if I'm visible, if the screen is visible.
Yes, sir, yes.
Yeah, so thank you so much and good morning to everybody. I'll probably spend about 25 odd minutes in just running through briefly on what works and what does not work from a radiologist perspective. I'll run you through a gamut of cases running from fluoroscopy to cross-sectional imaging and how we go about it in our day-to-day practice. By and large, when you're looking at the term dysphagia, it simply means that a person is aware that he or she has got a difficulty or there is an obstruction during the swallowing process of the swallowing mechanism. Numerous imaging as well as non-imaging techniques have been used as the arsenal for assessment of this condition, right from a diagnostic yield to a therapeutic, as well as a follow-up yield in terms of investigations. But the single most important feature, like in most of medicine, which is paramount and which helps getting to the particular diagnosis, is the patient's history. Now, if you go back to Dr. Chetan Bhatt's sir's lecture, it kind of very clearly and lucidly lists out all the major clinical dogmas which you tend to face when you're trying to assess this condition. And that's absolutely paramount before you're trying to evaluate anything using imaging or non-imaging techniques. Interesting to note is that when you're looking at a radiological classification, it just does not follow what exactly is done from a clinical standpoint of view, because there is a multitude of causes which can occur simultaneously in these patients. What we as radiologists tend to do is we divide it broadly into three gross areas in terms of anatomical as well as non-anatomical structural locations. The first thing which we do is we kind of localize the pathology into three levels. And ideally, we start with the oral cavity, then the transition zone, which is very critical, what I call the oropharyngeal or the hypopharyngeal region. And below that, we go to the substernal area, which primarily consists of the esophagus and the GE junction. So that's one way of looking at it. The second way of looking at it is from a functional or a structural standpoint of view. Imaging plays a significant and absolutely critical role when you're dealing with structural pathology. So when I mean by structural, I'm not talking so much on mucosal, but I'm talking beyond that. I'm looking at submucosal, mural, and extramural. Important thing to remember that the esophagus has a composite muscular nature. The upper third is primarily striated. The lower third is dominated by a non-striated or an autonomous muscle, and the combination of the two is seen in the middle. So you tend to get a plethora of pathologies which tend to affect the wall and the extramural area. And imaging really allows you to identify what's happening in the wall and beyond. The functional component is where you really have a lot of composite, or what I would say a hybrid approach requiring to diagnose a pathology. Usually you would have good clinical inputs, then you would have video fluoroscopies, you got fluoroscopic techniques using dyes, bariums, gastrographins, then you may have high resolution manometry, and then if required, cross-sectional imaging, which generally tends to play a lower role or has a lower value when it comes to functional imaging disorders. Please do remember that when you're looking at the location and the structural component of dysphagia, imaging plays a paramount role, though it's still an adjunct tool as compared to clinical diagnostic criteria. However, when it comes to the functional component, high-resolution manometry is the current reference standard or the gold standard for diagnosing esophageal motility disorders. And that's going to be spoken about in the next lecture. So now you have a kind of a location and a so-called a broad anatomical classification based on the structure, the function. Then you can kind of break it down into its nitty-gritties and say, what are the possible etiologies which can be the causative factor for dysphagia? And again, I tend to broadly divide this into two areas. The oral and oropharyngeal or the hypopharyngeal component tends to get pulled up into one category, and the substernal component has got a kind of a different milieu of pathologies which tend to affect it. Within both, there's a functional as well as a structural component, as I discussed earlier. And when I'm looking at the oral and the oropharyngeal, many of the time you're looking at cricopharyngeal spasms, or like Dr. Arun Shah said, a plethora of neuromuscular disorders, which can present either as a myopathy, a muscular dystrophy, or a neuromuscular dysfunction, which is a combination of the functional unit of both the neuronal as well as the myo unit having a abnormality. With all these three conditions which tend to have a functional component, please do not forget to look at a very big impact of dysphagia, which is the aspiration component, which you see in very often in neuromuscular conditions or neurological conditions. And this laryngeal penetration, which can occur at any time during the swallowing process, is what leads to aspiration pneumonitis and then the complications of aspiration pneumonitis itself. When looking at structural pathologies in the upper aerodigestive tract, they're relatively different from what you see in the substernal esophagus. The structural pathologies are primarily webs and diverticuli, and a larger quantum of these patients tend to have orohypopharyngeal tumors or even extrinsic causes of compression like a nodal mass, a large thyroid. You can get an abnormal cervical spine, which can cause compression or extrinsic indentation on the cervical esophagus or in the cricopharyngeal or the hypopharyngeal region. When you're looking at the substernal, it's a totally different milieu because the functional disorders tend to predominate in a significant amount of the population, and you're looking at pathologies related to peristaltic issues, changes in the pressure of the lumen, so you can get conditions like diffuse esophageal spasms, nutcracker esophagus, achalasia, sclerodermas, and so on and so forth. And then when you're looking at the structural component, of course, you got mural and a lot of extramural pathologies, and I'll show that in the following slides. By and large, from a radiology point of view, when you're looking at any condition which is affecting the swallowing process, which could be localized either in the oral cavity or the esophagus, or maybe due to any pathology which is either luminal, mural, or extramural, you are going to use fluoroscopy as the paramount or the single most important imaging tool to diagnose the condition. Of course, cross-sectional tools also have a significant role, but they are not the primary imaging tool which you want to do. Again, I want to tell you that in terms of cross-sectional imaging, you have three major modalities. You've got CT, you've got MR, and then you've got PET-CT. All three of them can be done with or without contrast imaging, both in the term of enteric contrast as well as intravenous contrast. By and large, CT and PET-CT tend to predominate. MR is usually a problem-solving tool when you're looking at either cardiac issues, vascular components, or you're looking at something which is coming out from the spine or the paravertebral area. If I want to kind of summarize this, one slide, fluoroscopy allows you to assess two major factors: what's happening to the lumen and what is happening to the peristaltic process. Whereas cross-sectional imaging allows you to identify the wall, which is very important, and what's beyond the wall, which most imaging or non-invasive non-imaging techniques fail to identify with a high degree of certainty or accuracy. If you look at the imaging, there are three different ways to actually do it. You could do it by doing the standard barium or the gastrograph and swallow. And then, of course, I'll be running through what happens during the swallowing process. You could do a modified barium swallow, wherein you bring in a speech therapist to come in, which kind of looks at not only the swallowing mechanism, but also the impact of therapeutic interventions and how the swallowing has kind of changed, which Dr. Arun Shah briefly brought about in his lecture just before mine. The third form is what we call the tablet form of swallows of fluoroscopic studies. And these are usually done when you want to pick up subclinical or very subtle areas of luminal narrowing, which may not be picked up when you're using a liquid like gastrographin or barium. For all standard purposes, I'm going to be showing you all how you do a standard barium or a gastrographin swallow, and it still has got a significant impact in day-to-day clinical practice and the management of dysphagia, not only the other components which are like globus and aspiration. So when you're looking at the mechanism of the swallow, it starts from the stomodium or the opening of the oral cavity, and it goes all the way down up to the GE junction and the stomach. And we tend to break it down into 8 phases on our standard barium or a gastrographic swallow. Now, the first phase, which you'd ideally get to see, is when the patient takes a bolus of barium. This is like putting food into your mouth. What are the 2 major things which tend to happen? So when a bolus gets into the oral cavity, the first thing you start to notice is that the base of the tongue and the soft palate tend to go a little more posteriorly, and they close the posterior aspect of the oral cavity to prevent spillage from the oral cavity into the open pharynx or the larynx. So that is the first phase of the oral propulsion of the food or the barium. The second phase, which you start noticing, is that as the tongue starts to roll backwards and propels that fluid backwards, what happens is, at this point in time, you still see that the larynx is pretty much open, and that's by identifying the position of the hyoid as well as the epiglottic cartilage. And also please note that the bolus of food or the fluid has not gone all the way back into the area of the base of tongue. So as of now, the soft palate has not completely elevated and closed up the nasopharynx abutting to the posterior pharyngeal wall. When the propulsion goes more posteriorly and now the liquid starts to coat the posterior surface of the oral tongue and therefore get into the BOT and the valleculae, this is the valleculae. Now what happens is the soft palate has to now move, and when it tends to move, it opposes itself with the posterior pharyngeal wall and kind of seals out the nasopharynx. This prevents the regurgitation of fluid from the oral cavity and the oropharynx, which is the anterior oropharynx of BOT, in the nasopharynx. Now, why is it so important? If there is a failure of the soft palate mechanism or the posterior pharyngeal wall to oppose each other, there is going to be nasal regurgitation. And this is one of the classical imaging findings which you tend to get when you have patients with neuromuscular dystrophies or with myopathies or patients with glossopharyngeal paralysis, which tend to supply, the nerve supplies the soft palate and the posterior pharyngeal wall, and failure of opposition of these 2 structures will present with nasal regurgitation. So whenever there's regurg, we tend to focus a lot into the oral cavity. Now, the first 3 phases, which I've kind of shown out here, constitute the oral phase of the initial or the swallowing mechanism. Now, this is very, very important because pathologies out here behave differently from what we see down below in the substernal area. Once the oral phase is done, the contrast of the food bolus is now propelled into the pharynx. Now, the pharynx has got 3 components. The nasopharynx has been sealed up during the oral phase of swallowing. And now what are the 2 remaining components are the oropharynx and the hypopharynx, which basically consists of 3 areas: the pyriform sinus, the postcricoid region, and the posterior pharyngeal wall. Now, what happens is when this bolus of contrast tends to come backwards and down, now you start seeing changes in what you call the hyperpharyngeal supraglottic region, and the hyoid bone tends to migrate rostrally. And when it tends to migrate rostrally, you actually have closure of the laryngeal inlet. It tends to do that, and the food is propelled. The normal tendency is now food goes into hypopharynx and does not get into the laryngeal inlet. This is absolutely critical. Failure of movement of the hyoid bone is going to cause an imperfect swallowing mechanism and a higher chance that this patient is going to aspirate at any point in time. Phase number 5. Now what has happened is the larynx is closed, but now the food bolus or the liquid has to propel further down. And when it needs to kind of propel further down, the middle pharyngeal constrictor, so there are 3 pharyngeal, the superior, middle, and the inferior. The middle pharyngeal constrictor will tend to contract. That is the indentation of the middle pharyngeal constrictor, and the fluid tends to go down and get into the region of the cricopharyngeus. And this cricopharyngeal bar, which is typically seen at C5, C6, tends to relax and pushes that fluid column down below the pharyngoesophageal junction into the cervical esophagus. Further contraction of the lower pharyngeal constrictor is going to propel this into the esophagus itself. So now what happens is you have now divided the upper component of swallowing into an oral phase, and the second component, which is again by 3 areas, or 3 subsects into the pharyngeal phase. This is very, very important, And this is primarily guided by a combination of a neuronal network and a myo network. And this neuromuscular coordination between the oral and the pharyngeal phase is absolutely critical for the food bolus to migrate into the esophagus. Once we have done these 6 phases and we have identified what's happening in the oral and the oropharynx, we also assess what's happening to the mucosa once the barium of the gastrointestinal has gone. And this is called the mucosal relief. And it's very, very important because it allows us to identify subtle contact abnormalities, any ulceration, any superficial tumors, any delayed leak of contrast from a fistulization secondary to a deep ulcer, and also tells you about the contouring of the residual column of the barium within the esophagus. Any lack of smoothness, more irregularity, any lumps and bumps, you can easily identify this on the mucosal relief very well. So this is very, very important. Now, once you've done with this component, you need to slightly go down. As we've seen the oropharyngeal and the hypopharyngeal phase, you also need to identify key landmarks in these structures. So the oropharynx has got an anterior oropharynx and a posterior oropharynx. The anterior oropharynx is the base of tongue. So we all consider the tongue to be divided into 2 parts: the anterior 2/3, which is purely the proper oral tongue, the proper oral tongue, which is within the oral cavity, and the rest of it is what we call the base of tongue, which is actually not part of the anatomical tongue, but as part of the oropharynx. This base of tongue basically is intimately related to 2 pouches on either side of the median glossoepiglottic fold, and that's called the valleculae. And you can see how the contrast of the relief has kind of pooled into the valleculae. Now, when you get tumors at the base of tongue, like one of the delegates asked this question, this vallecular space is kind of obliterated and tends to push the epiglottis posterior. You may see a component of dysphagia or a globus sensation simply because of tumor sitting in. I'll give you examples of the same. You go a little more laterally, but caudally, you tend to see those 2 air-filled recesses called the piriform sinuses, which are very beautifully shown in this image out here. The lateral outpouchings of the hypopharynx, and a very, very common location for the development of hypopharyngeal supraglottic tumors. Please do remember that once these structures are kind of covered up and the barium moves through, they tend to overflow and they go into the lower esophageal sphincter, the cricopharyngeal region, and then get into the esophagus per se. So we have finished the oral phase, we have finished the pharyngeal component, you have seen the neuromuscular coordination between both of them. Now go to the esophagogram, which is an absolutely vital component, because not just are you looking for anatomical deviations, but you're also looking for the smoothness of flow, the types of contractions which could be primary, secondary, or tertiary. You look for any condition which causes an extrinsic bulge or compression or deviation of the esophagus. Look at the mucosal relief for any subtle reticular pattern of the mucosa, any coarseness, any kind of ulceration, any leak. And lastly, but not probably extremely vitally, you look at the relation of the distal esophagus to the gastroesophageal junction and therefore the stomach. Now, please remember, a complete swallow studies assesses all these 3 components: the oral, the oropharyngeal, hypopharyngeal, and the esophageal phase of the swallowing itself. Once you're done with this, now this is what is absolutely critical when you're coming to the lower esophageal or the distal esophagus, the GE junction, or what people call the CO junction, and the stomach is the interface between the lower esophagus and the stomach cardia, the gastric cardia per se. The previous lectures have kind of highlighted the presence of the A ring, which is a muscular ring, and B ring, which is very often seen in endoscopic evaluation, especially looking at hiatus hernia. Probably in about 1 to 2 patients, if you're doing 10 cases of endoscopy, you might see easily in about 1 to 2 patients, you will identify the Shatsky ring, which is primarily a mucosal ring. You don't get to see that unless the G junction has migrated more rostrally. In the absence of a hiatus hernia, the possibility of seeing a Shatsky's ring is next to nothing or very, very low. Please remember the difference. The A ring is the muscular ring, whereas the B ring or the Shatsky ring, which is located at the squamo-columnar junction or the transition zone, is purely a mucosal or a submucosal based structure. Once you're done with just looking at the fluoroscopy, these are the 4 things which we tend to assess on every fluoroscopic study. Once you've got the normal anatomy sorted out, I'm looking for these 4 basic structures. Findings. Sorry, not structures, but findings. The first thing I'm looking for is the asymmetry. Any asymmetry in the flow of barium or gastrographin in the oral cavity, the oropharynx, hypopharynx, or esophagus, you have to raise a flag and you need to assess that area very carefully. Now, asymmetry could also be due to certain factors, like which could be a normal thing simply because air columns can look slightly different in the valleculae, the pyriform sinuses. The patients may preference follow through one area of because of a dental issue or because of some of the pathology. So it could be a normal finding. It could be due to rotation. Patients are not perfectly aligned when you're doing the fluoroscopy. But more importantly, whenever you look at asymmetry, you need to look for a pathology like paresis, neuromuscular dysfunction. You have patients with glossopharyngeal paralysis, with lymph nerve issues, very, very important. 10th and 11th nerve issues. And lastly, look for any tumor. The second thing is we always like to look for flow. How smoothly does the barium column move? Is there any holdup? Is there any stasis? That's the second thing. So failure of transit or a delayed transit or a delayed egress is the next thing which we look for, and that's called a stasis or a delayed transit. Once you've got these two sorted out, you want to look for something called the cricopharyngeal dysfunction, which could be either because of the bar being large enough, it kind of occupies a significant amount of the lumen, or it closes too prematurely, preventing the migration of the barium column caudally. So this is all seen only when you do cine-fluoro, not just one single snapshot images of these of the swallowing mechanism. Lastly, but which is very important clinically, that we've often forgotten, is the aspiration component of the swallowing mechanism. And if it occurs at any of the three phases, typically before the swallow, that means there is a leak of contrast because of insufficient closure of the oral cavity. During the phase, that means there is an incompetent muscular network or a neuromuscular network, which could suggest a paresis, or there's an underlying neurological dysfunction. Very often, you see patients coming in obtunded states, low GCS scores, patients with stroke, neuromuscular dysfunctions. And when we get our CT chest done in these patients, we see frank endobronchiolitis or basal consolidations with a lot of tracheobronchial secretions. And that's nothing because of reflux, failure of the neuromuscular junction to prevent the secretions from getting into the laryngeal airway or the tracheobronchial airway, leading to the development of aspiration pneumonitis. Following the procedure also, because of stasis in the pyriform sinuses, the valleculae, in diverticuli, you can get regurgitation and aspiration happening. And that's very, very important to note in all these procedures. So now that I've kind of gone through what are the etiologies, how's the mechanism, how we kind of identify these structures, I'll run through a battery of cases and show how imaging kind of works on it. The standard one, which we often seen on our swallow studies, is the cricopharyngeal bar, the cricopharyngeal spasm, or what we call the upper achalasia spectrum of disorders. And this typically means that the cricopharyngeal muscle is not relaxing to its totality, which prevents the barium column from migrating caudally into the cervical esophagus. Now, when is it significant? It is significant if the bar or the wedge of muscle occupies more than 50% of the lumen of the lower pharynx, or what you would call the pharyngoesophageal junction. Now, when this tends to occur, you identify it as a kind of a smooth shelf which is coming along the posterior surface or the posterior wall of the cricopharynx, and it kind of looks like a bar projecting inside. Only when this is more than 50% does it become significant in terms of the clinical outcomes. Otherwise, you may not want to do much about it. Please do remember that abnormalities of the cricopharynx can be occurring with other pathologies like Zenker's diverticulum, failure of laryngeal elevation, which is a very, very important mechanism, which I said right in the beginning while telling you the oropharyngeal phase of the swallowing, but it can also occur in patients with distal esophageal disorders, especially when you tend to have gastroesophageal refluxes or you've got abnormalities of the lower esophageal sphincter. One clue, a lot of times when you're looking at elderly patients, 50, 60 and above, is, and this is for practicing physicians, is that when you take cervical spine x-rays, the lateral x-rays, if you tend to see large osteophytes coming from the anterior margin of the upper and the mid-cervical vertebrae, you will actually see them causing a smooth indentation on the posterior wall of the pharynx of the upper cervical esophagus. Now, this is also a known cause of dysphagia. When you tend to get large osteophytes, paramarginal or paradiscal osteophytes, they can impinge on the esophagus. So whenever we are looking at the swallow, we're just not looking at the lumen per se, but we're also looking at other structures in the vicinity. So here, we would always make a note on what's happening to the alignment of the spine. If there are anterior osteophytes, what level are they? How big are they? Are they flowing? Are they discontinuous? And are they impinging on the posterior wall? Other conditions from the spine issue is something like DISH, which is diffuse idiopathic skeletal hyperostosis. And this usually happens when there is ossification of the anterior longitudinal ligament. More often seen in the dorsal spine, but you may see this in the lower and the mid-cervical spine, and that can also precipitate or present as dysphagia or just an abnormal sensation during swallowing per se. Lastly, you don't want to miss lytic lesions of the bone, expansive diseases like tumors, benign or malignant, which can have a mechanical effect on the cricopharynx as well as the hypopharyngeal region. This is very, very starting of the basic component when you're looking at the upper component of the swallow mechanism and the pathology which you see. Now, one of the previous delegates mentioned about base of tongue tumors or oral cavity tumors, and from a clinical standpoint and from a radiological standpoint, we place a significant importance for the role of cross-sectional imaging when you're trying to assess these pathologies. So here is a classic base of tongue tumor, which is now projecting into the vallecula. So we will remember clearly this component of the base of tongue has got a significant impact at between the oral and the oropharyngeal phase, failure for the barium column of the food bolus to go down. And you can see how the tumor is occupying or bulging into the pharyngeal lumen and obstructed. So that's a classic base of tongue squamous cell carcinoma. Where cross-sectional imaging actually comes to is not just the diagnosis of the localization of disease, but you want to identify the pathology, you want to stage it as regional nodes. Of course, you want to beyond the neck itself. You're not just looking at the neck, but you're looking at the cervical nodes, but you're also looking at what's happening beyond it. Plus, it allows us to plan for NACTs and radiation, and then, of course, post-treatment assessment, where PET plays a significant role. A couple of more examples. The first one is a BOT squamous cell carcinoma. This is a primary non-Hodgkin's lymphoma of the base of tongue. The base of tongue has got a lot of lymphoid tissue, which is de novo to that area. It's part of the Waldeur's internal ring, along with the facial tonsils and the nasopharyngeal adenoids. And that's where lymphoma is also unknown to occur and produce dysphagia. Here's something which is an uncommon condition. You have an absence of a thyroid. You've got a patient who's hyperthyroid, and you can see this ectopic thyroid coming at the level of the foramen cecum, which is ideally at the junction of the anterior two-third and the posterior third. Usually, these are seen as hyperattenuating mass lesions at the foramen cecum or just caudal to that, projecting into the base of tongue. And this is an uncommon cause of dysphagia as well. So many a times, when you don't have cause for the hyperthyroid and the gland itself is kind of absent, you need to start looking for ectopic thyroids. Of course, you're going to use nuclear medicine studies to identify the ectopic location, but cross-sectional imaging is absolutely pertinent to kind of not only diagnose the condition, but allow in the surgical management of these conditions. Coming a little more lower, so the oral tongue, base of tongue is kind of done. What you have is the hypopharynx supraglottic. And very often in our clinical practice, because you've got a very strong GI and a head and neck unit, you get to see these kind of mixed conundrum cases, which can present with dysphagia, but the pathology is not in the esophagus or at the cricopharyngeal junction, but a little more higher up in the hypopharynx. And that's a classical example of a pyriform sinus primary squamous cell carcinoma with metastatic nodes at level 2-3 of the neck. And that's what happens. So here in these cases, you want to use PET to identify which component of the tumor is active so that you can biopsy that component and also follow these patients to understand how these tumors respond to therapy. Here's a classic example of a pyriform sinus and a supraglottic tumor with extensive nodes. And then we give CT and RT. You can see that on follow-up, the node as well as the primary tumor have kind of resolved completely. This is a very good response assessment tool in the form of PET imaging. Of course, you can use CT as an adjunct tool as well. Coming to esophageal dysphagia, which is kind of different from the oral and the oropharyngeal components. Again, it's a functional as well as a structural composite. There couldn't be an overplay of conditions in both of them, but primarily you're looking at structural from a cross-sectional point of view, and from motility disorders point of view, you're looking at fluoroscopic studies in assessing these pathologies. So once you saw the cricopharyngeal bar at the level of the cricopharyngeal muscle, what you have come down just below that into the cervical esophagus, the classical example is the web. Usually it's seen in about 10% of patients on autopsy studies, can be either congenital or acquired, usually seen at the transition zone between C5 and C7 levels, and a majority of these tend to protrude from the anterior wall. The cricopharyngeal muscle protrudes from the posterior wall, whereas the esophageal web protrudes from the anterior wall. Many of the times the patient is asymptomatic, but if there's luminal compromise more than 50%, you would want to do something about in terms of excising these webs or kind of doing some kind of intervention in managing the dysphagia associated with these webs. More importantly, from a clinical standpoint of view, as Dr. Bhatt sir had very lucidly mentioned, you need to know the clinical presentations. Iron deficiency anemia, along with the webs, you know the composite is a Plummer-Vinson syndrome. And also please remember, though it's not much, but there is a potential chance of development of carcinomas in these patients, but is not as high as Barrett's esophagus or any other condition which tends to cause or is a predisposing feature for cancers. Foreign body, very often you see that in day-to-day clinical practice, not so much in our institution as compared to the civic hospitals, but you still get to see a good amount of them. The job of the radiologist is to more to localize it, whether it's still in the pharynx or the pharyngoesophageal component, or has it migrated and gone into the tracheobronchial airway, which can then cause significant airway compromise, and not just by the mechanical effect, but also by the inflammation and the surrounding swelling which it generates and blocks the lumen itself. So by and large, radiologists are there to look at where is it, how big is it, how far is it in its relation to the tracheobronchial tree, is there any abnormality in terms of wall disruption, what we call a perforation, any secondary complications. So here's a classical case where you have a nasogastric tube in the esophagus, but if you look slightly lower down or posterior to that, you tend to get a kind of a linear structure, which is kind of jutting out through the lumen, and that's a fish bone, which has kind of got impacted into the upper thoracic esophagus, or just at the cervicothoracic junction, which is a typical location. You can see that the bone has kind of perforated the wall of the esophagus, and there is evidence of mediastinal emphysema and mediastinitis, and therefore it can run the full kind of plethora of complications of abscess formation, mediastinal emphysema, fistulization with other structures, and of course torrential bleeders per se. So the job of the radiologist is not to identify where exactly and what is it doing, but also to assess for complications and guide the clinician very, very precisely in trying to do this. Here's an example of the same image. When I've magnified it, you can see the foreign body lodged in the esophagus, which kind of migrated through the wall per se. Once you've kind of looked at these kind of pathologies, very often you're on fluoroscopies, you tend to get what we call as secondary contractions. And what are secondary contractions? These are nothing but a wave of peristalsis, which tends to follow a primary peristaltic nature. These are benign, these are known to occur in a majority of the swallows, and these are propulsive enough. These are not non-propulsive, but they're not as propulsive as the primary contractions itself. You've got to differentiate these from the pathological ones like the tertiary contractions, the DES, which is a diffuse esophageal spasms, nutcrackers, and so on and so forth. These are kind of better evaluated on manometry studies, where Dr. Shobna is going to talk to you about them. But I'll look at just primarily a few of them from the fluoroscopic point of view. As compared to the first one where it shows secondary contractions, tertiary contractions are more random, typically seen in the mid and the distal third. But most importantly, these are non-propulsive. That means the column of barium or the food of the gastrographin will not migrate. When you do sequential evaluations, the column will remain in its position as compared to primary or even secondary contractions. Now, tertiary contractions, by and large, are localized to the mid and the distal third. You don't see them in the upper third, that is either in the cervical or the upper thoracic esophagus. Diffuse esophageal spasm is probably an extreme form of tertiary contractions, and usually it means there's an impaired inhibitory innervation. So there's continuous stimulation and the muscle is contracting, but there is no propulsion of food, and they usually present with severe retrosternal pain. A terminology which has been introduced is called Jackhammer Esophagus, which is a hypercontractile esophagus. It's not an imaging-based diagnosis. It's primarily based on certain parameters like DCIs on your high-resolution manometric studies, which kind of assess the changes in pressures during the swallow process itself. Run-of-the-mill stuff, which you often see, is achalasia cardia, which is basically a defective relaxation of the lower esophageal sphincter. More often than not, it's a clinical diagnosis. Radiology is used as an adjunct tool, primarily to differentiate between a primary achalasia, which is de novo due to a lower esophageal abnormality, or sphincter abnormality, from secondary achalasia, which is due to a malignancy of the lower esophagus or the GE junction. And there are certain standalone imaging findings like dilatation of the esophagus without peristalsis. You may see a retrocardiac fluid level. You could see markedly what we call a megaesophagus, which smoothly and rapidly tapers without any irregularity or shouldering at the level of the esophageal hiatus. This is a classical appearance of achalasia. CT is used, yes, if they are looking for ruling out an underlying pathology, any mechanical cause of obstruction, and also to assess for complications of achalasia like aspiration pneumonitis, which is very often seen in these patients. Also, post-treatment, in terms of helicardiomayotomies or a Dawes anterior wrap fundoplication, you want to assess what is happening to the transit of contrast. Is there a holdup or not? So this classic case shows on day one following an anterior wrap fundoplication that there is a smooth indentation on the barium column. There is delayed egress or holdup of contrast. So you know there's a mechanical component following the surgery, which tends to get relieved over a period of few days with reduction in the inflammation. Also, you like to look at post-treatment complications like pneumoperitoneum, which may suggest a small micro leak and often does not require anything, but anything beyond a micro leak will require some form of a surgical intervention. Scleroderma, once you talk of achalasia, you need to talk about scleroderma, kind of mimics of each other, but they tend to have a different presentation. Very important to remember that scleroderma is part and parcel of a multi-system disorder of the body. It tends to affect numerous systems. Gastrointestinal system is the third most commonest entity involved in scleroderma after the skin. Important to remember. Compared to achalasia, which is a dysfunction of the lower esophageal sphincter, this is primarily a dysmotility abnormality, which is coexistent with some degree of fibrosis, which lends to kind of shortening of the lower esophagus. Very often you see them to be dilated segments, more than 2 centimeters on CT with air fluid levels. And please do remember that because of the dilatation, you can get secondary lung findings. But also in scleroderma, you tend to get primary lung findings, which can be due to two features. One is a scleroderma-associated interstitial lung disease. And that's a classical example where I've shown you that kind of nodular or kind of that irregular septal, interlobular, intralobular septal thickening, which is seen in patients with scleroderma, and also because you can get pulmonary arterial hypotension, which can cause secondary changes in the lung parenchyma itself. Of course, eggshell calcification, there are of course numerous differentials for this, like silicosis, or asbestosis, but one of the conditions which tends to cause it is scleroderma by and large. Hiatus hernia, my previous colleague spoken to you this in detail. It's pretty much self-explanatory. What you tend to get is a classic B ring or the Schatzki's ring, which is a mucosal-based ring above the level of the GE junction, and that's a cynic 1 feature. It's what you find the Schatzki's ring as the apex of the hernia, not the core-most aspect of the hernia itself. We also use fluoroscopy and CT when you're looking at assessment of post-laparoscopic fundoplication related normal appearances as well as complications of fundoplication surgery. Reflux esophagitis, GERDs, always associated with Barrett's in a significant number of patients. You've got to be careful of this condition. It's not so much an imaging or a fluoroscopic diagnosis as much as an endoscopic diagnosis. But why you need to be careful is the potential that this is a pre-malignant condition, and therefore there's a chance that you can develop CA esophagus. So you need to be very carefully assessing any change in contour, any change in thickness. Look at the periesophageal fat for any kind of irregularity, fat stranding, or nodularity to rule out a cancer coming up out here. Corrosive strictures, depending on the phase, usually in the acute and the subacute phase, you want to be using gastrography. You don't use barium in these cases. You don't get to get strictures. It's more of an inflammation with esophagitis and then ulceration. But in the chronic phases, you tend to get these tight strictures, which need to get dilated. Always identify complications like perforations, fistulations, and also the possibility of developing CA esophagus in the long course. Pulsion diverticulums, you get to see this at multiple locations in the esophagus, typically at the mid area. Pulsion also is called traction diverticulum, usually some kind of a mediastinal process, fibrosis, nodes, which is tethering the esophagus and causing these diverticulums. Broadly dividing them into three components as upper, mid, and lower based on location. Based on mechanism, they can be divided into traction or pulsion, or based on pathology, they can be true containing all the walls of the esophagus, or just a herniation of the mucosa and submucosa through a muscular defect, which is a false diverticulum. This is a classical example of a false diverticulum, the Zenkers, which occurs at the level of the Killian's dehiscence, just above the level of the cricopharyngeus, whereas the pulsion is typically seen in patients with mediastinitis, mediastinal fibrosis, scarring, tuberculosis, and more often, the other form of a pulsion, which is often seen, is the epiphrenic, which is just above the level of the hiatus or the esophageal hiatus, and this is an ideal epiphrenic diverticulum. Important thing to remember about diverticulums is not that they are a harbinger for tumors, but the diverticulums are usually a harbinger for any extra esophageal pathology, or even for aspiration pneumonitis because of holdup of contrast within these diverticulums. Lastly, I'll look at C. esophagus. Fluoroscopic techniques are good enough, but cross-sectional imaging is the mainstay of assessment of C. esophagus. Why? It gives you good topographical assessment in terms of location. Very important for us to tell the physicians in relation to the GE junction and to the stomach. We don't not only assess the longitudinal extension, we also look at radial extension in terms of what's happening beyond the wall into the periesophageal fat, the relationship to the vessels, the tracheobronchial tree, the vertebrae, and the diaphragm. And more importantly, we need to stage in terms of nodal disease coming from the lower cervical, supraclavicular, mediastinal hilar, and the upper abdominal nodes. And these need to be very, very clearly articulated on your reports. Here is the PET composite of the previous CT, which you have seen out here, which you show a lesion in the lower esophagus going across the GE junction into the gastric cardia and the lesser curvature. And that's the PET equivalent of the same. Here, you can use the multiplanar reconstruction capabilities of CT, PET, CT to kind of co-localize pathologies very well. So here you have an upper thoracic esophageal tumor. You can see that the tumor has gone beyond the walls. It's indenting the tracheobronchial tree. There's a lot of fat stranding with nodularity. Look at the fat planes with the surrounding great vessels. This is surgically inoperable. You wouldn't want to downstage this with NACT and radiation before even considering any form of a surgical line. But ideally, this is a palliative line of management. The FDG PET kind of allows you to co-localize disease very well and therefore follow them up on post-treatment assessment. One important thing about CT is we also do CT. So swallows are not just left for fluoroscopy, but also do that on CT by giving either water or mannitol or a neutral contrast to distend the lumen. Because when you distend the lumen, you can get greater information on the wall of the esophagus. Normal thoracic esophagus is less than 2 centimeters in diameter. When it's kind of obstructed, it tends to become greater than 2 centimeters. The wall is usually less than 3 millimeters. Any wall thickness more than 3 millimeters is a pathological wall and requires further evaluation with endoscopy and EUS for any kind of biopsy confirmation. Yeah, just give me 2 minutes and I'll be done. Great response assessment tool also. You can see that the tumor, this is pre-treatment, and on post-treatment, this is what you tend to see on PET itself. Look at for thyroid nodules, aberrant subclavian arteries, endobronchial fistulization. And lastly, I just want to summarize this, that as a radiologist, patient history is critical. So I seriously depend on clinical input from like Dr. Bhatt's team, very, very importantly. You require a multidisciplinary approach to tackle this condition. Radiological tools are powerful, but they're adjunct tools. They're not the primary modality of investigation. Cross-section imaging tells you beyond what is happening in the wall and beyond. And what I would advocate to the physicians out here is that you need to have a hybrid case based on an individualized approach when you're tackling dysphagia for better radiological diagnosis. Thank you so much.
Dr. Usha?
Yeah. Thank you, Dr. Karthik Ganesh. It was a very nice, excellent representation, starting from the base of the trunk to the lower end of the esophagus. You had explained and your presentation was very excellent. And as a general physician, it becomes very difficult for us to interpret the radiological investigations of the patient. So you had very nicely represented it. Thank you so much. Now, any questions, Jitesh Bhai?
I don't see any just now.
There are no questions.
No, yeah.
Thank you.
Sir, are you there till end?
No, I may not be able to. If there's anything on the chat box, I'll kind of finish. I'll discuss that on the chat box if there are any questions.
Okay.
Okay.
Yeah, thank you.
Thank you so much. Now then, next speaker is Dr. Shobna Bhatia. I'll introduce Dr. Shobna Bhatia. 1 minute. One minute. Yeah. Dr. Shobna Bhatia is a consultant in the Department of Gastroenterology at Sir H.N. Reliance Foundation and Hospital and Research Center. She is a former professor of gastroenterology at St. G.S. Medical College and KM Hospital. After completing her MD, she did DNB in gastrology at KM Hospital, Mumbai. She underwent an advanced fellowship training in esophageal motility and pH at Philadelphia under one of the earliest innovations in motility. She was the recipient of Unichem Leadership in Gastroenterology and Indian Society of Gastrology Olympus Mitra Award for Endoscopy. She has also been honored with the NB Excellence Award by our Honorable Vice President of India, Dr. Venkaiah Naidu. She has a vast experience in the management of functional gastrointestinal disease, solid state manometry with impedance, pH metry, and breath testing. She has authorized many important papers and book chapters on esophageal motility, GERD, IBS, esophageal diseases, and dyspepsia. She is the chairperson for the task force on dyspepsia and a core group member for the task force on irritable bowel syndrome. She is on the editorial board of Indian Journal of Gastroenterology. Over to Dr. Shobna Bhatia. Thank you, ma'am.
Thank you, Dr. Usha. Can you hear me?
Yes.
Okay, so I'll quickly go through my slides. I think we are already very late, but can I share my slides? I'll just take that. So just a minute. So what I'll be talking about is esophageal motility disorders and how to diagnose them. Now, the first thing to understand, is my screen moving?
Yes.
Okay. So the first thing that we all know that the function of the esophagus is to transport food from the mouth to the stomach. And the two sphincters are the main ones which prevent any reflux that has to go backwards. So the lower esophageal sphincter will prevent gastroesophageal reflux, and the upper esophageal sphincter will prevent reflux from getting into the lungs, or what we call as aspiration. Dysfunction of the esophagus or its motility can lead to dysphagia, it can lead to reflux, and it can also lead to chest pain, what we often cause as non-cardiac chest pain. So all the speakers before have insisted that history is the most important part of looking at dysphagia. So some of the questions that we usually ask, some of them have already been talked about. Do you choke or cough when trying to eat? What do you have trouble eating? Solids, liquids, or both? Does it happen with every meal? Where does the food get stuck? Is the regurgitation bland? Then in that case, it's esophageal. If it is sour, it is coming from the stomach, which means there is gastroesophageal reflux. Is there heartburn? Often in patients with achalasia, there can also be some heartburn. And when did it start? Now, unlike mechanical dysphagias, where the patient usually remembers when the dysphagia started and has worsened, in motor dysphagias, they sometimes tell you 1 year, maybe 2 years, or maybe 3 years. And finally, in today's day and age, we have to ask, is there a history of ingestion of opioids? though we always associate opioid ingestion with constipation and pain in abdomen, an important new aspect has come up that many of these opioid ingestions can also lead to dysphagia, which is motor dysphagia. Now, this is a slide some of you may have seen. Chetan Bhatt was also explaining it in a different way. So motor dysphagia usually is for solids and liquids simultaneously. It progresses over years. And if the patient tries to make maneuvers like repeated swallows or straightening the back, then in that case, there is some improvement in dysphagia. Patients often complain that if they have sensitivity, if they eat hot or very cold substances, they can have worsening of dysphagia with chest pain. And usually weight loss is not such an important thing. Quite often, if you talk to the family, they will tell you that this person has been eating very, very slowly. He can take up to half an hour, 1 hour to finish his entire meal, but usually their appetite is normal. And because they finish their whole meal, you do not have much of weight loss. So what are the techniques for diagnosis of motor disorders? The first is high resolution manometry. Dr. Karthik Ganeshan did talk about it. And the other one is high resolution impedance manometry, which I will be touching upon. Timed barium and details of barium, Dr. Karthik has already talked about. And endoflip is something which is a new technology which is not available here. So I'm not going to touch about it. So let us look at high resolution manometry. And there are two types of catheters. One is the water perfusion catheter. The other is the solid state catheter. Sufficient to know that the solid state catheter is more sensitive. It can pick up even smaller, very minor changes in pressure. It can be combined with impedance, which means we can look at flow of substances, which I'll come to. And both these can be attached to the computer as you see below. What we have is the latest version of the solid state manometry catheter. Along with that, we also have antroduodenal manometry, which tells you about patients who have delayed gastric emptying and gastroparesis. So the most easiest part of the test is to put the catheter just like you put in a Ryle's tube and position it at the distal port, position it in the stomach. Then, as you see here, you see that the catheter has gone through the nose into the stomach. And there are two sphincters here. This is the upper sphincter. This is the lower esophageal sphincter. And the proximal part of the esophagus is skeletal muscle. The distal part is smooth muscle. And in between is the transition zone. So when you look at the graph for this, you find that the upper esophageal sphincter pressure normally is very high. The swallow is very rapid. And this is where the solid state catheter comes into use. If the water perfusion is a little slow in picking up pressures, then in that case, the cricopharyngeal opening and closing, which take less than 200 milliseconds, cannot be picked up very well. Whereas the rest of the esophagus can be picked up because it is a little slow. As you see, smooth muscle, the pressures rise slowly, come down slowly. And at the LES, you see that the pressure is high and then the LES opens or relaxes. Now, this is the older system. And last about 20 years ago, Dr. Ray Klaus from St. Louis decided to convert these graphs into colors. And when you look at these colors, it is very easy to analyze this. The darker colors here, you can see this marker. The darker colors are the higher pressures. The lighter colors, that is the blue colors or the dark blue colors, are the lower pressures. As you see, the stomach has very low pressure. The thorax around the esophagus has very low pressures, whereas the esophageal contraction has high pressures. So we have converted waves to color. Now, if you simultaneously give barium and do a manometry, you will find that when the bolus is flowing down, that means when we are eating, the esophagus is actually relaxed. It's only when this point is crossed that you start seeing the pressure wave. That means the bolus is in front of the peristaltic wave. And that is where, in order to find out whether the bolus is moving or no, that means whether the food is getting stuck or no, besides the pressure changes, these things can be made out when looking at impedance. So this is an example of when we are doing the manometry. As you can see, there is a high pressure zone here, which is the upper esophageal sphincter. There is a high pressure zone here, which is the lower esophageal sphincter. This blue down is the stomach. And when you give a swallow, the esophagus, when the bolus arrives at the upper esophageal sphincter, it opens, which you can see as the pressure going down. Then there is peristalsis, which means the pressure is higher. This is the peristaltic wave, and the lower esophageal sphincter has opened, which means that the pressure has gone down, and the bolus then moves on into the stomach. Keep about 30 seconds between the two swallows so that the esophagus has a chance to recover its contractility and there is no deglutative disinhibition. So here, when we combine barium, as I showed in the previous chart, you see this blue is the impedance, which during manometry, you can see the flow of the bolus. And this is the contraction of the esophagus, which we saw in the previous picture. And based on this, we come to conclusions as to what is happening in the esophagus. So in impedance, what you see is that initially, because we're using saline, the impedance goes down and it comes back, and you see it exactly as you would see in it's the reverse of your peristalsis, and this is the peristalsis. So the impedance catheter is slightly different. That means it has the solid state pressure catheters along with these impedance points, and both of these can be measured. So if you measure manometry alone, this is what you see. If you measure impedance alone, this is what you see, which is the bolus. And when you combine it, this is what you get to see. So this is again the same thing, that this is a normal bolus transit. The upper esophageal sphincter has opened, the bolus has started going down, and this is the peristaltic wave, which is coming and clearing the bolus so that the bolus empties into the stomach. So from here, I'll take up a few cases and then take up what is to be done with them instead of showing you classical what happens in manometry. So this is a 30-year-old lady, dysphagia since 3 years. The dysphagia is localized to the mid-sternum. Solids are equal to liquids. It's non-progressive, and there's absolutely no weight loss. Whenever a person comes with dysphagia, before we take up the patient for manometry, we have to be sure that this is not a mechanical dysphagia, which means either barium or an endoscopy has to be done to show that the mucosa is clean. So in this case, a barium was done, and you see that there is a bird beak appearance, there is a fluid level, and here we then did a manometry. Of course, it's indicated here because this is a non-mechanical dysphagia. And what you see here, that there is absolutely no peristalsis. The previous slide, we showed peristalsis, where the bolus was moving from one end to the other. Here, there is absolutely nothing. The LES has not opened at all. That means there is bolus stuck at the level of the lower esophageal sphincter. The esophageal body is aperistaltic, and the pressure in the esophagus, which is green, is higher than that in the stomach, which is blue. That means there's a lot of residue lying in the esophagus. This would be termed as type 2 achalasia. The second one is a person with dysphagia for 10 years. That means he hadn't really noticed it. He just kept on having this dysphagia, which was mild. It was not giving rise to any weight loss. But surprisingly, he had 2 episodes of aspiration pneumonia. And that is what you will notice in this barium, that the esophagus is so dilated. This is the esophagus. This is the cardiac shadow. This is the esophagus. It was so dilated that, and there was a lot of food residue inside. So the moment he lies down, the food starts coming back into the throat, And that is how he had 2 episodes of pneumonia. This is the same patient with a very large esophagus. These kind of esophagus on barium are also called as sigmoid esophagus because they are so turned up that it is difficult to identify a straight esophagus in these people. So here, when you do the manometry, what you realize is that the esophagus is so dilated, the muscle has become totally flabby. There is absolutely no tone left in the muscle. So even after swallowing 5 ml of liquid or even 20 ml of liquid, there is absolutely no response in the esophagus. The LES has not opened. That is, the lower esophageal sphincter is still closed. There is absolutely no response. And this type is called as type 1 achalasia. Now, exactly opposite to the type 1 is a case where this boy has intermittent dysphagia, which is associated with severe chest pain. When there is chest pain, we know that there is a lot of spasm going on in the esophagus. And sometimes these people can have a little weight loss because of chest pain. They are scared to eat. But again, this is an intermittent dysphagia which has worsened over the last few months. And here you see this classical corkscrew esophagus, which Karthik also showed us as a nutcracker esophagus. And in this case, again, the barium is held up at the lower esophageal sphincter, and you try and do the manometry, you find that the pressures are extremely high. And you see another picture of another patient where as soon as the patient has taken the swallow, the esophagus has gone into complete spasm. And the patient develops severe chest pain at this point. The bolus is not moving into the stomach. The LES is not just opening. And these are people whom we would classify as a spastic achalasia or a type 3 achalasia. Sometimes we feel that this is the earliest part of achalasia when the patient starts having symptoms before they start developing continuous dysphagia or they start developing aspiration. This is the earliest type of achalasia in a given patient. And in some patients, you can actually show a progression from one type of achalasia to the other. Now, in achalasia, we know that there is food getting stuck in the esophagus. And there is a fluid level which we see in bariums. Now, we know that barium can be done either as a straightforward fluoroscopy swallow, or it can also be done as a timed barium. Now, in patients, when we are doing the manometry, when we use impedance to check whether there is fluid in the esophagus, even between the swallows, we find that there is a liquid level here, which is similar to the barium level that you see during a barium swallow. And this impedance bolus height often correlates with the barium. And in case we do not want to do multiple bariums to assess the response of achalasia treatment, we can easily do a impedance and check whether the fluid is getting stuck and causing distension or residue in the esophagus. This is very important to find out before endoscopy, because if there is a lot of fluid in this esophagus, then in that case, the patient can develop aspiration during endoscopy. Now, this is a slide of an opioid ingestion, which quite looks like a peristaltic wave, but you see that this part is not peristaltic. There is an element of spasm here. The LES is relaxing, and this can be mistaken for a distal esophageal spasm or a nutcracker, and sometimes early achalasia if the history of opioid ingestion is not available. So during the history taking itself, if a history of opioid ingestion is available and the patient has dysphagia, we suggest that the patient stop the opioids for a few days before a manometry is done. Otherwise, we would be mistakenly causing them, calling them as esophageal motility disorders, and suggest treatments which may even be surgical or endoscopic, instead of just asking them to stop the opioids. This is an example of what is a jackhammer esophagus. This is the severest form of spasm of the esophagus, where when we calculate this distal contractile integral, which I haven't defined, is a combination of the amplitude, the time, and the length when we calculate this, if this is more than 8,000, that means this is a severe spasm. It actually tells us that this patient is likely to have dysphagia because the esophagus has gone into severe spasm. Sorry. However, this is not achalasia because you see that this is peristaltic. In a different slide previously that I showed, there was achalasia. It was everything was simultaneous and the whole bolus was stuck in the whole esophagus. The bolus is seeming to move forward. There is emptying. The LES is opening, but there is also severe spasm, which is lasting for more than 15 seconds. There is also an entity called as secondary achalasia, which Karthik talked about. And here it is the history which tells us that this is not primary achalasia. So secondary achalasia is because a growth at the level of the LES or at the level of the fundus of the stomach has infiltrated the muscle fibers of the lower esophagus. And when you do an endoscopy, that's one of the things that we always say. During an endoscopy, look at the fundus of the stomach before you say that this patient has primary achalasia. And here you find that there is a growth sitting there. And on a barium swallow, Karthik showed a similar one. You see that the LES does not have this classical bird beaking, but there is a lot of filling defect in this area, which is exactly what you're seeing on an endoscopy. So in patients who have secondary achalasia, we suspect it when there is a short duration of symptoms, when the patient has weight loss, and the patient is usually 50 or 60, above 50 or 60 years of age. So other causes of esophageal dysphagia are hiatal hernia and gastroesophageal reflux. Surprisingly, gastroesophageal reflux, when the esophageal muscles become weak, they cannot push the bolus forward, and therefore the patient may feel dysphagia, though sometimes there is no bolus obstruction. What there is bolus escape. So in hiatal hernia, as you see here, this is the upper esophageal sphincter, this is the lower esophageal sphincter, and there are two high pressure zones. One high pressure zone is the lower esophageal sphincter, which has moved up into the thorax. The second high pressure zone is that of the diaphragm pinch, which is here. Sometimes in patients with hiatal hernia, the diaphragmatic pinch is quite strong and it is not widely opened out. And these are patients who can have a food impaction inside the hiatal hernia, and they can have dysphagia as well. Now, when there is severe reflux, you find that the esophageal muscle is not contracting well. And you see here that there is absolutely no contraction. And then you see in the next slide, you find that when you add an impedance to the study or you use the impedance catheter, there is escape of this purple color here, which means that the muscle is not contracting well. There is a large break in the continuity of the muscle contraction, and therefore the fluid is actually escaping from here and tending to remain in the esophagus even after the peristalsis is over. And this is where the patients feel that they may still continue to have mild dysphagia, or they feel that the food or the liquid is stuck here. I'm going to only present one slide of pharyngeal assessment because Dr. Arun Shah has already spoken in great detail, and Dr. Karthik has spoken about cricopharyngeal dysphagia and bars. But I just have to talk a little about the aspiration risk. When you do this pressure topography, place the same thing in the upper esophagus. This is the point where the upper esophagus sphincter is opening. This is a zoomed out picture from the previous pictures where you saw the whole esophagus in one go. Now here, this is the upper esophageal sphincter which has opened, and on the right, you see the flow of the impedance, which is the bolus transit. Now, when you compare this, you find this is the pressure as you show it here. That is the bolus going down, and that is the second one. This dotted line is the pressure, which means the bolus has cleared completely before the upper esophageal sphincter closes and the pharyngeal contraction is complete. Now, based on these parameters, there is a special software which analyzes this, and tells us whether there is an aspiration risk. The aspiration risk is important for neurology patients, where you can teach them how to swallow based on these findings. And this swallow risk index, if it is more than 15, it is considered that this patient is likely to have repeated aspiration and aspiration pneumonias, which is why they need treatment. I'm sorry, this has gone into a replay mode. So what are the indications? So when will you send a patient for manometry? First and foremost is non-mechanical dysphagia. If you suspect that the patient has achalasia, diffuse spasm, nutcracker, that is straightforward. But if an endoscopy has already been done in a patient with dysphagia, and there are no ulcers, there is no tumor, there is no stricture, then this is the indication for manometry. And based on manometry, a treatment can be planned. In patients who have gastroesophageal reflux, I showed you all that they may have dysmotility, they may have a hiatal hernia which can cause dysphagia. But more importantly, and most importantly, before sending a patient of reflux for surgery, which is the fundoplication, we have to do a manometry, and that is mandatory by most of the societies in the world. In addition, we also have to prove that the patient genuinely has reflux by doing a pH metry, which I am not going to cover today. The reason for this is that very often patients have mild heartburn, they complain of regurgitation, but do not have gastroesophageal reflux, but turn out to have achalasia, as I showed you in the type 1 achalasia, where a lot of fluid is sitting in the esophagus, and the patient keeps regurgitating that, and that is misinterpreted as gastroesophageal reflux. So therefore, in patients of reflux prior to surgery, we have to do a manometry. So last is prior to lung transplant, because there the acid is actually responsible for causing rejection. Therefore, acid assessment has to be done prior to lung transplant. Thank you for a lovely afternoon, and I hope you all enjoy swallowing your lunch.
Yeah, thank you so much, Dr. Shobna Bhatia. It was an excellent representation. Nicely, madam, you are there, no, still end?
Yes, I am there till the end.
Okay, then we'll move to the next speaker.
Yes.
Dr. Smita Ragaukar. I request IMA CGP member Dr. Sachin Patharkar to introduce the madam. Over to Dr. Sachin Patharkar.
Good afternoon, everyone. Dr. Smita Nagaonkar is a consultant at the Department of ENT at Sir H.N. Reliance Foundation Hospital and Research Center. After finishing her MBBS and MS ENT, she completed her DNB in Otorhinology. And just a minute. She completed her DNB in Otorhinology and head and neck surgery. She did a clinical fellowship at the Queen Elizabeth Hospital, Adelaide, Australia, South Australia in 2005, and John Hunter Hospital, Newcastle, Australia in 2007. She has served as a consultant ENT surgery at Mayo Private Hospital, Tari, Australia. She is actively involved in conducting functional endoscopic sinus surgery workshop at both national and international levels. She has numerous research papers to her credits and presentations in national and international journals. Her areas of expertise include endoscopic sinus surgery, head and neck cancer surgery, advanced endoscopic sinus surgery, micro-ear surgery, cochlear implants, phonosurgery, and endoscopic middle ear surgery. Today she will be speaking on evaluation of pharyngolarynx. Over to you, madam. Thank you.
Smita ma'am, are you there? Unmute yourself, yeah.
I'm trying to share the screen.
Yeah.
And can you see the screen?
Yeah.
So good afternoon, everyone. Basically, I would like to thank Mehta sir, Usha ma'am for this opportunity for me to be able to part of this interesting seminar. I would also like to thank Bhatt sir and Shobna ma'am for considering ENT as a part of this particular activity. I would say that most of the speakers have covered all the important areas. I would like to just shortly touch base on the examination part of the laryngopharynx, which is an integral part of when we are evaluating patients with dysphagia. Okay, so anatomy as such, we know that there is something called as nasopharynx, there's oropharynx and laryngopharynx. We are today concentrating mainly on the hypopharynx examination as we are evaluating case of dysphagia. However, starting from lips, as Bhatt sir has showed in his very first slide, that it starts from the lips and goes down up to the upper level of the lower level of the esophagus. So the entire portion. Laryngopharynx is the area which I would like to show here on the screen, which is lowest part of the pharynx, which lies behind and partly on the sides of the larynx. Its superior limit is the plane passing from the body of the hyoid bone to the posterior pharyngeal wall, while the inferior limit is the lower border of cricoid cartilage. So basically, it is the inlet for the food to get into the esophagus. Now, so what we see when we evaluate patients of dysphagia in ENT practice as such, patients do present with difficulty in swallowing, but sometimes there are overlapping symptoms wherein they also complain of foreign body sensation at the back of throat. There are patients who only present with some associated symptoms in addition to dysphagia, and those other symptoms include earache. They do complain of coughing with swallowing. Some of them do present with weight loss. Some of them have got accidental history of ingestion of foreign body or still have got suspicion of foreign body, change in voice and neck swelling. Again, would like to reinforce that detailed history is very, very important. We cannot at all ignore this fact. Although we have got the most state-of-the-art investigating modalities, however, history is the main part when we are dealing with any patient. Actually, I believe that history gives us clue in pinpointing what would be the next plan for the patient. So each and every aspect of the history needs to be tackled very particularly. We give importance to chief complaints, duration of the complaints, associated symptoms. If there are any addictions, as Shobna ma'am said, that opioid addiction, this is one of the important things which can present as dysphagia. And this is the clue which we still are not open about asking opioid ingestion. So addiction becomes a very important pointer of the history. A relevant past history, comorbidities, surgical history, if there was any history in the neck or the mediastinum, which probably could have affected the recurrent laryngeal nerve. This becomes again important aspect of the history. Drug allergies. And again, as sir mentioned very clearly, there is something called as pill esophagitis. So, that part needs to be covered as well. When we go in with history, we have the pointers to look for things. So examination is the next area where we take our patient to. This is how we would examine our ENT patients typically. We go ahead with first to begin with oral cavity examination, then becomes oropharyngeal examination, and that the next is the laryngopharyngeal examination, which we are going to talk about. Neck examination becomes integral part of ENT examination. Although we are talking about swallowing, sometimes patients do complain of referred pain, which is otalgia. We do need to look for any associated ENT issues also at the same time, so that we don't miss out on any additional finding which would be present in the ear at the same time. In olden traditional ways, we used to do indirect laryngoscopy with the ideal mirror, which is now replaced with rigid video laryngoscopy. And next is the flexible laryngoscopy. I'll come to that a little later. So basically, both the examination part are essentially meant to look for the passage of the oropharynx followed by the laryngopharynx, wherein we use rigid laryngoscope, which is attached to the camera and connected to the monitor, wherein we can see a magnified view of that area, which allows us to do a meticulous examination from base of tongue to the vocal cords. So I personally prefer flexible video laryngoscopy over rigid laryngoscopy because it is more comfortable for the patients. We don't have to literally pull the tongue and pass the rigid scope through the oral cavity to look for the larynx. Also, added advantage as ENT, I feel we are going through nose, so we get to see the entire passage and we don't miss out on the top portion of the nasopharynx as well as the soft palate when we are viewing that part. Typically, this is how we get to see the larynx. We get to see the arytenoids, we get to see the vocal cords, we get to see the false vocal cords, piriform sinus very clearly. And since it is a magnified view, it is very easy to find out the minute of the lesion or mass in that area. So once we've collected this basic history examination part together, then we have a plan for the patient, whether this patient requires any further ENT evaluation, does he require any endoscopic evaluation of swallowing. Then we come with appropriate referrals to the different teams in terms of whether they need GI evaluation, whether that person particularly requires radiological evaluation. And to put everything together, all these patients with dysphagia, we do get our speech and swallow therapists involved because they are integral part of treatment plan of these patients. They do teach. So what do actually speech and swallow therapists do? So they actually come up with different maneuvers, different tips and tricks to help patients with dysphagia to deal with their different areas of the handicap. I'll come to that shortly. So first, let me tell you all what we do in functional endoscopic evaluation of swallowing as such. That is called as FEES, F-E-E-S. So this is what is everyone is talking about. We started this very early in 2005 when we started the hospital. We used to do this particular exercise in voice clinic and voice and swallow clinic in Australia very regularly. So the referral base for this particular clinic is from onco, from neuro, from GI team. So essentially what is done on these patients who have difficulty in swallowing or have got any particular complaints related to the voice. So a procedure is used to assess how well one can swallow. This is actually a biofeedback. We get to see visually exactly what is happening with the bolus when patient is actually swallowing. This is always done in presence of speech and swallow therapists so that they also get to see exactly what is happening in that particular patient when they are eating, so that that particular information can be made use of when they're giving the therapy sessions at later stage. So what we do is a thin flexible scope is passed through the nostril, which has got it's around 2.6 millimeters to 3.6 millimeters. It varies in diameters depending upon the surgeon's choice. That particular scope is attached to a camera and a light. So we get to see a magnified view of the particular procedure. This particular scope passes through the nasal cavity and sits above the epiglottis for the most of the viewing. And that is the time when different consistencies of food is actually introduced to the patient through the oral cavity, and they're asked to swallow while the scope is physically in there, and we are able to actually physically see what is happening to that patient's swallow mechanism. Okay. So during first phase of this particular test, the normal structures of the pharynx and larynx are observed. We look for any physical abnormality if it is seen, any pathology that is seen before we subject patient to the food, introduce food in them. So how well one can swallow their own saliva, that is what is actually looked at to begin with. And then second phase, we introduce the food. So food is introduced in different consistencies, starting from the thin liquids to the solid food. We also make sure that there is a colored food is sort of introduced so that there's a good contrast on the background of the pink pale lining or the congested lining. As you can see very clearly on this image, how we are using the green colored food. It's a palak puree to look for the actual, get a good contrast and look for the movement of the bolus. It's very nicely seen with the contrast. And when that particular bolus is moving, we get to see whether it is following the natural mechanism or it has got any kind of a delay there, or there is a premature spillage, or there is penetration, or there is any aspiration. And at the same time, different maneuvers and head positions are tried if any particular handicap is picked up, to see if that can be corrected only by doing those kind of a maneuvers and head positions. And this is where the role of speech therapist becomes very integral, because they get to be part of this particular discussion so that they can carry out those follow-up sessions with them, and they can actually assess patients' progress. So findings, what we get to see while we are doing this particular phase are either the worst being the aspiration, where you get to see the food bolus directly getting into the tracheobronchial tree. And that is the reason why we do not introduce the big amounts of bolus. There is a catalog that we follow. We have to introduce very minimal amount of food to begin with to see how it is moving. And that's when we go with the second next step of like starting from 1 ml to 2 ml and then going on up to 5 ml. We look for premature spillage, which is again a neurological condition wherein actually patient doesn't have control on their sort of oropharyngeal phase. Because of the weakness of the muscles, they can't control it, and the actual material is propelled straight onto the larynx, and before even epiglottis close and give good protection, it can fall into the tracheobronchial tree, putting patient at risk of aspiration. So residue coating on the walls of hypopharynx can be noted, and that can also act as a focus for the further penetration and aspirator. So basically, this is something very important for us to know, because a lot of patients are not able to sense that the food residue is still there. They feel they've swallowed everything, but then there is some residue that continues to stay there. And this is where I feel fees is of utmost importance. And this is where that gap between the other investigations and this particular investigation is wherein you actually physically get to see the bolus which is stuck here and there, and where the residue is not cleared. And that particular residue in neurological patients can act as a potential risk for the aspiration. Okay, so what do we, apart from aspiration, penetration and causes for dysphagia, what do we look when we are doing this particular test? We also look for laryngeal inflammation, we look for vocal fold mobilities, we look for how much the glottic closure is happening. Is there any phonatory gap that continues to persist that can act as again reason for someone's aspiration? Pharyngeal contraction, how much is the participation of pharyngeal wall into the swallowing mechanism? Speed of the swallow, is there any premature spillage or not? Again, secretion management is something very important, wherein we get to see a lot of pooling of saliva for patients. We can detect the load of saliva that is seen visually. You get to see while patient is not sensing that, and that's where we need to tell patient, where speech and swallow therapist takes over that role to remind them to swallow periodically, even they don't feel there is anything. So saliva needs to be pushed in on regular intervals, although they don't sense it. Coordination of, if there is any incoordination of breathing and swallowing. So this is again where speech and swallow therapy gives their sessions are of utmost importance to the patient, and we give those biofeedback to the therapist. We have a discussion as to which muscle needs to be acted on more, and then they take over the therapy sessions after that. Okay, so this is how physically we do it. We've got monitor in front of the patient. We put scope through the patient's nose. It's exactly like a flexible scopy as I showed you earlier. However, at the same time, while scope is in, we introduce food at the same time when we've got that view going on. The upside of this particular test is that we can assess the sensory awareness of the structures. We can comment on that. It's a quick procedure. It's done in the OPD. There is no pre-requirement as such. We just take patients from OPD. We call speech pathologist, and that's the team that's required. That's it. There's no radiation involved in that. We can use biofeedback for the speech and swallow therapist to help them with their therapy sessions later on. And these minute details and discussion as a team gives patient also confidence. There's like a bridging gap that they feel that, okay, doctor has spoken to the therapist knows what to do that, and then they are taken for the therapy sessions. Therapy sessions are carried out over a period of time, and when therapist feels that there is a check scopy required, then patient is brought back over a period of 6 weeks, 8 weeks, 3 months, depending upon the clinical condition and patient's response to the therapy. The time period varies though. And we have a portable machine which can be carried with us to the wards or ICU, and that helps critically ill patients who cannot actually come down to the OPD. So this is all about the basic OPD examination, but sometimes dysphagia becomes a little not able to figure out what's happening down there, and patient may require direct laryngoscopy or microlaryngoscopy under anesthesia, which works as a diagnostic tool to find out what's going on physically there. And if at all there are any suspicious lesions or something, we can take a biopsy at the same time. Sometimes when there are any strictures or a kind of small webs, this particular under anesthesia procedure can become more of a therapeutic procedure as well as diagnostic at the same time, because you can just do the dilatation at the same time. Well, thank you for your attention. This was my little short presentation to tell as to how we evaluate the laryngopharynx. Thank you so much.
Now there will be a panel discussion.
Dr. Usha, you can hand it over to Dr. Chetan Bhatt now. Dr. Chetan Bhatt, please take over.
Yes, let the screen go, please. Okay. Now, can everyone see my screen?
Yes.
Okay. Now there are a lot of questions. I've seen few of the questions on the chat box, and this is time for me to now finally wrap up and tell you the final approach to the dysphagia. It was a very extensive coverage of dysphagia by every speaker, and by any standard, this was very extensive. And I know it is very difficult to digest at the same time all the information you got, but I'll simplify only in 2 slides. Only in 2 slides, I will tell you what you can do in your OPD, in your clinic, or a person asking you for the advice. Now, the medical history, as we all discussed, is a very important, and history taking gives you the most of the time diagnosis. And it is always a conventional wisdom that talk to your patients, because 90% of time you get your diagnosis by listening to your patients. So if there is a difficulty in starting swallowing, or when you start swallowing, there is a cough and there is a choking or a nasal regurg, probably you're looking at the oropharyngeal dysphagia. So when somebody has got a pain or difficulty in throat area or coughing or nasal regurg or choking, probably and there is a history of CNS disorder, there is a history of hemiplegia, or there is a history of myasthenia gravis or Guillain-Barré or some other neurological disorder, you directly refer to the neurologist. If there is a pain while swallowing, or there is a discomfort while swallowing, but there is no CNS deficit, you can refer to ENT specialist. If there is no pain such, but there is a chronic pain going on for the last few weeks or months, and patient has lost significant weight, you can do CT scan of that area or MRI of that area and refer to even a head and neck surgeon also, because there could be a malignancy sitting in the pyriform fossa or a pharyngeal area. So this to signify and satisfy and everything, this is the first approach. There's oropharyngeal dysphagia, and I'm simply simplifying it very much for everyone. Second, you move beyond the oropharynx, and the food is getting stuck in the esophagus beyond the cricoid bone, cervical esophagus or lower down. Then there's esophageal dysphagia. The first question then here is it for the solid and liquids both equally, or it is only for the solids? If the dysphagia is for the solid and liquid both, then probably you're looking at a motor disorder. There's a neuromotility disorder of the GI tract, and it can be intermittent or it can be progressive. If it is intermittent, it is primary esophageal motility disorder, or it could be even a secondary esophageal motility disorder. If it is progressive, the chronic GID symptoms, chronic heartburn, then it could be scleroderma with a dysmotility of the esophagus, dilated peristaltic esophagus. It can lead to severe reflux and even a later stage stricture also. So you can refer to a gastroenterologist here, and that too you can refer directly for the manometry here. But before referring to the manometry, should I do barium or a cine radiography or a contrast X-ray examination, or I should do CT scan? I'll answer in the next slide. Second is the regurgitations or respiratory symptoms and weight loss, and there is a progressive dysphagia, significant weight loss, female patients 30 to 50 years of age group. You're looking at achalasia cardia. So again, the contrast X-ray examination of the esophagus and maybe CT scan, and then maybe you can ask for the manometry. If the dysphagia is only for the solid and it's a mechanical dysphagia, it is non-progressive, probably you're looking at esophageal web, esophageal ring, or esophagitis, that is the eosinophilic esophagitis. If it is progressive with a chronic reflux kind of symptoms, then probably it is a peptic stricture. Or if it's an elderly person, significant weight loss, anemia, you're looking at a malignancy of the esophagus or a G junction. So the gastroenterologist and endoscopic examination can be done in a solid dysphagia. Now, what to do first? To first do barium examination or video fluoroscopy examination or a coronary examination or CT scan or endoscopy or a manometry. I'll answer in the next slide. So next slide, the person has history of any surgery or esophageal cancer or complex strictures or radiations in the past. If there's a history is present, if there's any surgery done in the oropharyngeal area done in the past, or a dysphagia is in the oropharynx, you can do video fluoroscopy or a contrast, which is not a barium. If barium person aspirates, person can have a problem. So you can do basically coronary study. Coronary study you can do, and a video fluoroscopy you can do. But if there is no previous history of any surgery or any complex strictures or any radiations, then you can straight go for the upper GI endoscopy. So whether to do barium or cine radiography or a contrast or endoscopy depends upon any previous pathology or previous surgery. If the person has done a previous esophageal surgery also, or previous thoracic surgery which you don't know, go for the contrast X-ray examination of the esophagus and oropharynx area. If you've done the esophageal endoscopy or upper GI endoscopy and you've taken a biopsy, if there is a structural abnormality like ring, web, stricture, diverticulum, erosive esophagitis, tumor, infective esophagitis, eosinophilic esophagitis, you can treat accordingly. If the upper GI endoscopy is normal, I mean, mild reflux, esophagus appears normal, G junction appears normal, pyriform fossa is normal, arytenoid is normal, closure of arytenoid is normal, epiglottis is normal, then probably dysphagia only to the solid. Do barium if barium is not done previously, and you look for the another structure abnormality like a web or an extrinsic compression. Why web is missed on endoscopy? Because some people use a very thin endoscope, pediatric endoscope, or a very thin size endoscope, less than 9 millimeter. So if the web is more, there's about 12 millimeter or 15 millimeter size, or even sometimes 20 millimeter size, then it is missed with a small endoscope. Or a person misses the esophageal web, which is in upper esophagus, and he may report as a normal upper GI endoscopy. So in that case, it's better to do a barium X-ray or a contrast X-ray and then repeat the endoscopy if required. If there is a dysphagia to the solid and liquid both, and you already done upper GI endoscopy, go for the esophageal manometry. Now, if you have done the barium when the upper GI endoscopy was normal, and a barium showed any structural abnormality, you treat accordingly. If the barium is also normal, then you go for the manometry. So you start with a barium or a cine radiography. If that is normal or there is surgery done in the past or any pathology in the past, you do that. There's nothing in the past and there's an esophageal dysphagia, then go for the upper GI endoscopy. Now, upper GI endoscopy shows pathology, you treat accordingly. Then you do CT scan, MRI, PET CT scan, whatever needs to be done, you do it. If upper GI endoscopy is normal, you can go back to the barium examination. Barium will tell you about the diffuse esophageal spasm. It can tell you nutcracker esophagus or jackhammer esophagus. It can tell you about a diverticulum better than a endoscopy sometimes. And that is also normal. Barium is normal. Then you go for the manometry. Manometry will tell you about the secondary esophageal motility disorder, which is seen in a systemic sclerosis, the scleroderma. It can be seen in a diabetic autonomic neuropathy, or it can be primary esophageal motility disorder. Or if the esophageal manometry is not giving you any correct idea, it's equivocal, then again you can go for the barium examination if it has not been done earlier. If it is done, just give a symptomatic treatment and wait and watch, and don't do anything at this stage. If the patient is not losing weight, dysphagia is intermittent, dysphagia is not progressing, and there is no aspiration pneumonia. If even esophageal manometry is normal, then probably you may be looking at a early eosinophilic esophagitis or a GERD, which is mild or nocturnal GERD, or a very complex type of GERD, which is not picked up. Then probably you require a pH metry, which Dr. Sobna Bhatia did not cover, because pH metry is to diagnose the GERD. This is a very basic, simple dictum for the which examination to do for the dysphagia. So with this, I say thank you. And any questions for the panel, I'm open for the questions. Dr. Shankar, you are there?
Dr. Chetan Bhatt?
Yes.
Yes, sir, I'm here, but my video has some issue.
No problem. No problem.
Yeah. Thank you, Dr. Chetan Bhatt, for giving an excellent representations. You are the real professor and teacher for us as a general practitioner. It becomes very easy for us. You have represented so nicely that as a general practitioner, we can understand all these things.
Thank you, Shaben. Thank you very much.
Now, Dr. Jitesh Mehta, please, will you share the question answer?
I think Dr. Chetan Bhatt has covered most of the questions, and he has answered all those pertinent questions that are, excepting there was one question regarding FESS. FEES, that is the patient compliance. Now, it is easy for the patient to have a scope and swallow food.
Mostly everybody has covered everything, so there is not enough any questions.
Smita, the question is for you, whether FES is comfortable for the patients to do it in OPD.
Yes, sir. Sir, I don't even use topical this thing now. I don't even use xylocaine. I mean, that is what the whole idea is, because once you put xylocaine, you're compromising the sensations. So the scope is put without any topical anesthesia or decongestant. And it's been done very, very comfortably for the patient. The scope diameter is around 3.2 millimeters to 3.6. So there's very easily tolerated by patients, sir.
Thank you for answering.
I will ask one question from the doctor's side to Dr. Sobna Bhatia and Dr. Shankar. What about the pathology outside the esophagus, like a lymph node or something compressing outside? Endoscopy appears normal, correct? Manometry, how comfortably you can pick up that, number one. And number two, what will you do if you see some bulge compressing the esophagus from outside on endoscopy?
Sir, I could not hear your first question. Second question I could hear. If there is a bulge. So if there is a
compression, lymph node or a aneurysm or a malignancy from outside compressing, and somebody does not have EUS, what should be the approach at that stage?
Sir, if the practitioner who is doing endoscopy and does not have EUS, the first line of investigation in absence of EUS will be a cross-sectional imaging. Contrast CT will be the best. Once we have a contrast CT, the lesion can be identified, but the problem with contrast CT here will be, it would be just an image in hand. It won't give the tissue diagnosis. So if one is expecting to have tissue diagnosis, then obviously EUS has a upper hand. But if the lesion is accessible through the CT, it could also be done very well. Only the problem is the chances of pneumothorax on CT guided aspiration or CT guided biopsies is much larger than transesophageal endosono guided biopsies.
No, I tell you why I asked this question, because one medical student in final MBBS, every time she would sit in the library to read, she'll start coughing, and she will have a mild dysphagia. She had done various examinations that time, everything normal, and people thought it was psychogenic. And 6 months later, it turned out to be lymphoma around the upper esophagus, and 6 months later, she died. Correct. So this kind of cases where the pathology is outside the esophagus, so the endoscopy reported as a normal.
Yes, exactly.
Correct. So that time one has to understand, please pay respect to the patient's symptoms. If the patient is still complaining and the symptoms appears to be organic origin, please continue observation or your investigation and go for the tissue diagnosis. Correct. So how will you handle such cases, Sobna?
So same thing what Dr. Shankar said, that if the patient is a young girl who has recent onset symptoms, motor disorders is not on my mind as the first diagnosis. I would still go and chase for a structural disorder. And if the endoscopy was normal, I might even take the liberty of doing a second endoscopy, but I will do a CT scan or a barium before that to see if there is any extrinsic lesion, because lymph nodes which are lying outside the esophagus can sometimes be mistaken for an aortic compression or a cardiac compression. And doing a manometry is not going to add anything to the diagnosis. It is just going to tell me that there is a compression, but I have to investigate for the cause of compression. So therefore, if there is an extrinsic compression, it's always a mechanical disorder, and this patient should not have come to the manometry room at all. This is not an indication for manometry.
Now, one more question. There are so many GERD surgeries taking place, and I had shown you the Nissan's fundoplication.
Yes.
So now the reflux has gone, patient has got dysphagia.
Yes.
So what should a general practitioner do? Patient was referred for the reflux. Surgeon has done the surgery. Bariatric surgery has been done. Now patient has come with the dysphagia.
Yes.
How can this be taken now?
So therefore, here we actually try to figure out how much is the dysphagia and whether the patient had dysphagia before. So therefore, one of the slides I showed, I said we have to do manometry before. Because if the patient has severe dysmotility right in the beginning, and the patient has dysphagia even before the surgery, then in that case, it means that the esophageal peristalsis is really poor. And by tying the fundoplication even normally, the patient is going to have a worse outcome because the food bolus is not going to cross even that slightly tight LES. There is no strength in the esophagus.
Correct.
In these cases, the surgeon has to previously decide that this patient will require a loose fundoplication. There are many techniques and the surgeons are the best to describe those, but the patient requires a loose fundoplication. And of course, in these cases, the reflux does not completely go away because you are not tightening the LES as much as you wanted to. The patient will continue to have dysphagia, and then we have to investigate accordingly and treat. If the dysphagia is too much, we might even do that we have to pull down the fundoplication in such a case.
So I'll simplify this answer for the audience. The answer is that a long-standing chronic GERD will take esophageal permeability also. The lower end of the esophagus stops contracting very well. There's an aperistatic esophagus. Now in this esophagus, you do surgery for the reflux. Then Usama, you need to mute. Usama, you need to mute.
Yeah, there's a lot of background noise. Yeah.
Usama, so in this kind of cases, before the surgeon goes for the fundoplication, the manometry should be done. And if there is an aperistatic esophagus or esophageal contractions are very poor, surgery should not be done ideally, or a loose surgery should be done.
Correct.
If the esophagus is contracting very well, there is no problem, then probably it's a very tight fundoplication. So that can be dilated with a balloon or a bougie, or it can be also even undo surgery can be done. Relaxed surgery can be done. Correct. Now, if somebody has got a scleroderma or a diabetic autonomic neuropathy, reflux and a dysphagia due to poor peristalsis, how do you tackle that, Sobna?
So the treatment is similar to a person who has severe dysmotility with gastroesophageal reflux. Here again, we have to discuss with the surgeon beforehand and tell them that if the reflux is really too much and it is causing even aspiration pneumonia, only then should we go in and do surgery. Otherwise, medical treatment completely block the acid. But if the patient has a lot of volume reflux, that there's a lot of fluid coming up, then again here a partial fundoplication as we discussed earlier. So a partial fundoplication is what helps these patients. A total fundoplication is a disaster in patients who have scleroderma because there is absolutely no motility.
And one question was asked, about doxycycline and which doxycycline should be used and what is the guidelines, everything. Answer is very simple. The cheap doxycyclines are acidic pH, pH 2. And the costly doxycyclines are, which is about 10 rupees per tablet, they are alkaline pH. So ideally, if the person can afford, you can use this. But if the person is genuinely poor, cannot afford the costly doxycycline, then even if you give a pH 2 doxycycline powder form, that ask him to take with 1 glass of water. 8 ounces of water should be ideally taken with the doxycycline, and make sure that you are upright for some time. That's number one. Number two, many people have a habit, like many people have diabetes, hypertension, other disorders, IHD. They take 4 or 5 tablets together and eat 4 or 5 tablets together. That should not be done. Do not take multiple tablets together, number one. So even if you take 2 tablets, maximum 3 tablets, and drink a glass of water, wait for 10-15 minutes, again take 2 tablets. But many times somebody is breakfast table, 5 tablets before the breakfast, 5 tablets after the breakfast. Correct? So don't take 5 tablets together, and don't take with a just sip of water. I've seen many doctors also, while talking, they put a tablet in the mouth and they swallow without the water, with the saliva. Don't do that. Don't do that. Every tablet, especially antibiotic, NSAIDs, quinolones, various antihypertensive, IHD drugs, clopidogrel, they all require large amount of water. You have to drink water, that you remember. If you do that, you can keep the pill esophagitis away, and you can treat pill esophagitis before it occurs. Jitesh bhai, any question from your side?
You have covered everything. Thank you so much.
Everything, yeah.
Yes. Thank you.
It was a very nice session. Thank you so much.
Very nice.
Dr. Chetan Bhatt, Dr. Shobna Bhatia, Dr. Smita Nagaonkar, and all other speakers. Now I request the last ceremony of the session. I request Assistant Secretary CGB Subfaculty Dr. Kajal Ahuja to give a vote of thanks.
Good afternoon, all. I would like to thank our speakers of today's webinar, namely Dr. Chetan Bhatt, Dr. Arun Shah, Dr. Shankar Zanvar, Dr. Karthik Ganeshan, Dr. Shobna Bhatia, Dr. Smita Nagaonkar. I also thank our knowledge partner for the day, Sir H.N. Reliance Hospital. I thank Mr. Dipen Mehta, Mr. Piyush Kale, Ms. Vaishali Tanpure from DigiShield, who have given us the platform for this webinar and handled all the technical details at the same time. I thank Dr. Anil Awad, President-elect, for conducting the webinar smoothly and efficiently. A big thank you to our immediate past President, Dr. Sujatu Nisa Attar, for being the MMC observer for today's session. Last but not the least, I thank you all the delegates for participating in this webinar in large numbers and making it a grand success. Thank you very much.
Thank you. Thank you.
Thank you.
Thank you so much.
Thank you.
so
Thank
much.
you.
Thanks.
Thank you.
Bye-bye. Thanks.
Bye.